Good afternoon. I'm Dr. Stephen Church and would like to welcome you to our CME webinar sponsored by Kentucky Hands and Voices. The topic for our webinar, as you might expect, is CMV or cytomegalic inclusion virus. The purpose of this webinar is to increase your knowledge of this widespread illness that can affect all age groups that is particularly harmful to children, especially our premature and small for date children. CMV affects 4.5 children out of every 1,000 live births. When CMV presents in the newborn period, it has a wide variety of presentation. In 90% of the children, they may have few symptoms or even be asymptomatic, while 10 to 15% of babies, especially our small predates and prematures, will have severe illness, sometimes even life-threatening. The illness can affect their eyes, their ears, their brain, their development, the blood system, and even their overall development. Of those, when CMV affects the ears, it is the leading cause of non-hereditary sensory neural hearing. What's most frightening about CMV is that from the 90% of children who have few symptoms or are asymptomatic, many of them will go on and develop symptoms later in the first few years of life, a period most critical for their development. 10 to 15% of the children will develop hearing problems, some so severe they need cochlear implants. This hearing loss, late detected or undetected, certainly has an adverse effect on their development, both academically, socially, and overall development. To better inform you about the causes of the significance of this problem, our webinar is divided into two parts. The first part is more academic, and we have an expert panel who are going to discuss CMV. Our panel, Dr. Laura Sadler, pediatric infectious disease, Dr. Kent Iverson, otolaryngology, Dr. Aprita Lakota, neurology, Dr. Dan Stewart, neonatology, Dr. Shelley Motes, audiology, and Dr. Julia Stevens, ophthalmology. And they will discuss the CMV effects that they see in their particular areas of specialty. The second part of the webinar will introduce you to families who have children with CMV so that you can see the real toll that this illness takes on these children and their families. Just a little housekeeping before we start. If you have any questions during the talks, please put your questions in the chat box and we'll try to answer them. Now let us begin with Dr. Sadler.
Hi, everybody. My name is Laura Stadler, and I'm a pediatric infectious disease specialist at University of Kentucky, Kentucky Children's Hospital. Today, I'm excited to talk to you about congenital CMV. In terms of disclosures, I have no financial conflicts of interest. And the objectives of the talk are shown here. I'm going to review the current epidemiology of congenital CMV infections in the United States. I'd like to discuss the signs and symptoms of congenital CMV infections. I'll talk very briefly about the treatment of congenital CMV infections. And lastly, I really want to focus discussing screening for CMV in an effort to identify candidates for antiviral therapy. Many of you are aware that June is CMV Awareness Month, and the National CMV Foundation has supplied these slides of the three themes that they have tried to emphasize to the U.S. Cytomegalovirus, or from here on out I may continue to say CMV, is common. It's thought to be the most common virus transmitted from a pregnant woman to her unborn child. 1 in 3 pregnant ladies who get CMV will then pass the virus on to their baby. It's thought in the U.S. That the percentage of babies born with congenital CMV is roughly 1%, or some estimates are 1 in 150 children are born with congenital CMV infection. Perhaps the most important thing shown on this slide is that congenital CMV is more common than the 29 combined metabolic and endocrine disorders in what's referred to as the recommended United States newborn screening panel. So when we think about screening for infant metabolic screening for our state, CMV is more common than the 29 disorders that are already included. The next thing that the CMV Foundation wants to emphasize is CMV is largely preventable. It's my hope that during my career, we will have a vaccine available to prevent congenital CMV infection. Until then, the measures are largely common sense. They're easy to do. So the CDC and others have endorsed strict hand washing with soap and water for those who come into contact with young children. We know that pregnant women who have young children in the home, work with young children, are at the highest risk for having CMV. Some of these measures may seem very common sense: to avoid direct contact with saliva of children under the age of 6, to wash your hands after contact. There are a lot of studies in children attending daycare or childcare centers of both the children and the parents of children attending daycare, and they show that infection is quite common. It's spread by saliva and urine. So our childcare workers should be using what we refer to as standard precautions. This is soap and water, washing their hands with gloves with each and every diaper change when they're doing diaper changes for young toddlers or babies. Other common sense recommendations are shown here: to refrain from sharing utensils, drinks, or toothbrushes in children under the age of 6. The last theme is that CMV is serious. Every hour, one child is permanently disabled by CMV. It's thought to be the leading non-genetic cause of childhood hearing loss. CMV may cause vision loss, mental disability, microcephaly, cerebral palsy, behavioral problems, and seizures. In our country, it's thought that roughly 400 children die per year from CMV. But there is a connection between miscarriage and stillbirth, so this may largely be an underestimate. I like to include a parent perspective, and this quote is from Tracy McGinnis. She's the mother and founder of the CMV Foundation and the Brendan B. McGinnis Congenital CMV Foundation. She describes her story that after 4 miscarriages, her son Brendan was born. She thought he was the picture of perfect health. Holding him was a miracle to her, a dream come true. But she goes on to say that the hearing evaluation showed he had neurologic hearing loss, and this was the beginning of life as I knew it being forever changed. I was crushed thinking my son would be deaf in 1 year, but little did I know this was just the tip of the iceberg. The news came. It was CMV, and the doctor spoke of cerebral palsy, seizures, deafness, blindness, mental retardation, and more. And what occurred in the years since then are a number of tests, procedures, and surgeries. Brendan's brain incurred severe injury from the virus, and he now sees a number of specialists. Brendan is severely disabled both physically and intellectually. He cannot crawl, sit up, or walk. He's nonverbal, has seizures, is fed through a G-tube, and has severe cerebral palsy. And she goes on to talk about how he receives multiple therapies 4 times a week. And she shared our story with us. She's a huge advocate for congenital CMV and has established this foundation for vaccine research in hopes that other families, that this may be prevented in the future. This next slide shown here is part of the CDC's effort to educate childbearing women. And in preparation for a vaccine, it gauged childbearing women's awareness of conditions affecting children. And I often direct you down to the bottom of the slide and work upwards, in that the majority of childbearing women have had HIV screening offered to them. The majority of them, people have discussed trisomy screening, trisomy 21, and other screening early in the pregnancy. The majority of OBs, obstetricians, and pediatricians talk to childbearing women or pregnant ladies about the Back to Sleep campaign, putting your infant down on its back, such to prevent what's referred to as SIDS. The CDC has come out to say that no amount of alcohol is acceptable during the pregnancy in an effort to prevent fetal alcohol syndrome. 3/4 of women know to take a prenatal vitamin during the pregnancy to prevent what's referred to as neural tube defects or spina bifida. For those ladies who carry a baby to 36 weeks gestation, about 60% of them are aware of group B strep, or group B streptococcus screening that occurs at that time, and they know their status when they come in to deliver. Only about half of pregnant women know about something called congenital rubella syndrome, but all ladies are screened at their first prenatal visit. The majority of childbearing women in our country are vaccinated with rubella-containing vaccine, and this is not so much of an issue. Only about a third of pregnant women know about something called toxoplasmosis, but for those who have cats in the home, they're rather pleased to learn that they're no longer in charge of cleaning the litter box. Even less, 1 in 3, know about something called parvo. This may cause high drops and other things when they're a baby. So the CDC really brought to our attention that only 1 in 5 women is aware of CMV or has ever heard of cytomegalovirus. And I see this a lot in my clinical practice, in that often when I need to go talk to a parent or family of an affected baby, the mother will say, "But I was tested for everything. I've never even heard of this." And this is part of our efforts to educate people and make them aware of this condition such that they can use prevention techniques to prevent infection. CMV is the leading cause of birth defect and disability in the US. The data that's cited here is from 2005, but at that time it was thought to be CMV can cause 8,000 children having long-term problems, and sadly 400 deaths per year in the US, as compared to other conditions, fetal alcohol syndrome, trisomy 21, spina bifida, and other infections including HIV, something called Haemophilus influenza, and congenital rubella syndrome. This is the leading cause of birth defect and disability in our country. This slide shows you a schematic of cytomegalovirus. It is a human herpes virus 5, and it infects a broad range of cells. And many people will say it's ubiquitous, meaning it can be in many different body fluids. The schematic on the left, I showed you mostly to show some of the viral glycoproteins. And GB is one that has been used for subunit vaccine candidates in our country. And so that has been part of our vaccine strategy here in the US. In terms of symptoms for a first-time or primary CMV infection, it's often referred to as infectious mononucleosis, or mono for short. Whether it be young children or young adults, this CMV infection can cause rather nonspecific signs or symptoms. So fever, fatigue, malaise, sore throat, or swollen lymph nodes, particularly in the neck. And so pregnant women may not necessarily come to medical attention or may not seek out care from their OB if they have a fever and a flu-like illness, because there's nothing very specific about it. And we often say that this may be subclinical, meaning the woman may not tell her OB that she's been tired, as that's a common complaint during pregnancy. CMV can be transmitted by these body fluids, particularly saliva and urine, and that's why young children are particularly a risk for infection for pregnant ladies. In terms of the classic presentation for congenital CMV, we think that it's when primary or first-time infection occurs during the pregnancy to the mother. Thankfully, the incidence in pregnant women is low at only 1 to 3%, and 2/3 of these babies will not become infected. However, for those who are infected, 10 to 15% will have symptoms at birth. So just as a reminder slide, this is thought to be the most common virus transmitted to the fetus, with 1 in 750 children born with or developing disability due to CMV. Of the long-term problems, hearing loss is thought to be the most frequent long-term sequela or problem. This estimate shown here at the bottom is actually from 2000 from the Institute of Medicine, and it was preparing for vaccine candidates. At that point in time, almost 21 years ago, the estimated healthcare costs were roughly $2 billion a year. I attempted to find some more recent estimates. There are some estimates from the Netherlands that clearly has a different healthcare system than we do. And there are some lower scale estimates, but I could not find anything more recent than that. But if you think about what $2 billion was 20 years ago, it's a sizable amount for the financial cost of CMV. I often show this slide, which baby has CMV? to our medical students. And the majority of them will hone in and look at the baby on the left. Okay? And the baby on the left has some aspects of jaundice, or what we refer to as hyperbilirubinemia, yellow skin. The baby also has petechiae or purpura. These are purple spots that don't blanch, or some people refer to this as a blueberry muffin rash. And often trainees will say, oh, the baby on the left has CMV. But I use this slide because the baby on the right could just as easily have cytomegalovirus and be without symptoms at birth. So this is why screening is so important, that we are able to identify infants to potentially offer antiviral therapy. So the data for the birth cohort for 2020 in the United States was actually just published last week. It was thought to be 3.6 million live births, a little bit down from previous years where it was approximately 4 million. But if you assume that congenital CMV infection represents roughly 1% of annual live births in our country for this year, roughly 36,000 infants in the US are infected with CMV. If you look at the left side of the slide, of those, 10% will have symptoms, but sadly, 80% of them are going to have long-term adverse outcomes or problems. As compared to the overwhelming majority of the babies, 90% are not going to show us signs or symptoms at birth. However, 10 to 15% of those babies, by the time they go to school, kindergarten, first grade, they will have 10 to 15% of them will have some associated hearing loss. And so it's very important that we develop a system to screen babies without symptoms and to offer therapy to infants in the first 3 weeks of life. CMV causes hearing loss. It's a leading cause of environmental, non-hereditary, or sensory neural hearing loss. And it represents 20 to 30% of childhood hearing loss. What's interesting or unique about it is that it's progressive. And so that means that an infant may, on the very first audiology evaluation, have normal hearing or mild loss. But with time and without antiviral therapy, infants may lose some of that hearing or have progressive hearing loss by the time they're 5 to 6 years of age. That hearing loss tends to be late onset. So that's part of the reason why our babies will go to audiology every 3 months in the first year of life, followed by every 6 months thereafter. We want to be able to maximize their development and their speech and language. And so if the baby does have hearing loss, we would offer them certain therapies that some of my colleagues will talk about in other talks, such as hearing aids and or cochlear implants. This slide shows the spectrum of symptoms. And on the left side, we have babies that are born very symptomatic. And sadly, some infants may not even make it to term. So mom may have a miscarriage or stillbirth. We have had some infants who die shortly after birth. And those are incredibly traumatic and just devastating for families. On the other end of the spectrum, there are infants that could be born with CMV infection, but not have any symptoms at birth and do relatively well and be asymptomatic by school age with no visible delays or impairments. We find at our institution, where we do have universal screening in our NICU, that when we identify babies, they likely are somewhere here in the middle. It's very difficult when you meet with parents or a family for the first time, because oftentimes they want to know, is my baby going to be normal? What can I expect my baby is going to be capable of? And so some of those are the most difficult conversations to have, because we know that infants may be somewhere on the spectrum. There are some things that can help us predict for families in terms of hearing loss, vision loss. But it's very difficult, especially when you first meet a baby, to know what the future holds. And so I just share with you because there's a large spectrum of symptoms shown here with lots of disability associated. This slide shows some of the outcomes that infants may show us. On the left side, the transient outcomes shown are things that we may see in the nursery or neonatal ICU. So on exam, we may see a big liver, big spleen. We may see yellow skin or jaundice. we may see that blueberry muffin rash I talked about. Infants may have trouble breathing or have pneumonitis. They may have what we call intrauterine growth restriction or be very small for their size. And sadly, infants may have seizures in the newborn period. Some of the permanent outcomes are shown over here on the right in terms of having a small head size, which is predictive of decreased cognitive abilities, hearing loss, vision loss, mental retardation, motor disabilities, seizures, and even death. And so these are rather difficult to talk about with families, but we need to prepare them for the possibility. So I have some clinical slides. This first one is from what we call the Red Books. That's the American Academy of Pediatrics section of infectious disease. It's kind of our Bible. And we're excited that sometime this month, the 2021 version will come out. And so this is a slide of a baby. He's very sick from CMV. The baby does have that blueberry muffin rash with petechia and purpura. Baby also has some jaundice that you can appreciate, or yellow skin. And you can see on physical exam that the liver, both the liver and the spleen have been outlined. These are rather large for age. The baby has a big liver and big spleen. And so this infant appears to be very symptomatic. And sadly, at 48 hours of life, this baby died of CMV. At autopsy, 2 major organs found the presence of CMV and confirmed the diagnosis. And so this is a devastating case shown to you. This next slide shows microcephaly. And so that is defined by CDC as less than 3rd percentile for both age and sex. And so some schematics are provided here from the CDC. A baby on the far left with typical head size, let's say a full-term baby, the average head circumference may be 35 centimeters. And if you're a well-seasoned pediatrician or neonatologist and you go to a lot of deliveries, if you were to see an infant with perhaps a head circumference of 25 centimeters, this baby would definitely have microcephaly. And this is a very concerning physical sign that babies can show us that basically the brain did not develop normally and likely will have some cognitive abilities, as well as concern for hearing and or vision loss. This slide here is the picture of this blueberry muffin rash, which is thought to be representative of what's referred to as extramedullary hematopoiesis. This rash may be seen with other congenital infections, so it's not specific to CMV, but obviously it would alert healthcare workers to evaluate the baby for congenital infections. In white or Caucasian children, we can also see what's referred to as hemorrhagic lesions, or some people may call these more petechial in appearance, so we can see these in white children as well. This is another infant with a large liver and spleen. Baby also has an element of what's referred to as ascites or fluid in the belly, and so these are other symptoms of CMV. This picture here, a couple of different pictures we've got looking at intracranial calcification. So this top left picture is actually an ultrasound, and so this is pretty easy to do, and that regardless of how sick the baby is, a transducer can be put over the baby's head, and pictures can be taken. And so this radiologist has been kind to alert you that there's a calcification in this yellow, and so this kind of white area on the head ultrasound is supportive of a diagnosis of CMV. In cases in which we either are highly suspicious of congenital CMV or we've confirmed it and we don't see calcifications on the ultrasound, the American Academy of Pediatrics tells us or recommends that we should go to a CT. So this picture in the upper right and the lower left of this slide is a CT of the brain. And so you can pretend that you're on the floor looking up, and these are slices of bread. Okay, so these are cuts of brain images. And these 4 black areas are what we refer to as the ventricles, where the spinal fluid will drain. And these white or kind of hyperlucent areas here, you can appreciate that they're lining the ventricles. And that is classic for CMV. So if we saw in a CT of the brain that we had these white spots or these calcified areas lining ventricles, And then slide down here in the lower left, you can appreciate this white area lining this ventricle. This is supportive of a diagnosis of CMV, and this infant would be categorized as moderate to severe with regard to the symptoms, okay, and would be offered therapy. And this very last picture is actually a 4-month-old baby. It's provided by the American Academy of Pediatrics. And just remember, as a radiologist, you're required to report on your field of view. So whatever you see, you must report. And so while the skull film was probably performed for some other reason, you can appreciate there's kind of this white area in the middle, kind of hyperlucent area that the radiologist would be required to report as part of the skull film findings. And whoever had ordered that test would then be obligated to consider CMV, and there's another congenital infection that can cause calcification. So basically, if we see calcifications in the brain, despite it being a 4-month-old, we may still be able to make a diagnosis for this baby and family. Next, I show chorioretinitis, and thankfully this is only seen about 20 to 30% of the time in babies with congenital CMV. These slides are provided by an ophthalmologist, and the one on the left is kind of described as a brush fire distribution, where you can appreciate these kind of white, the distribution seen by the ophthalmologist is brush fire, okay? And the picture on the right is kind of perivascular infiltrates in the retina. And so both of these would be supportive of ocular involvement and would be concerning for that baby's long-term vision. This slide here shows cumulative hearing loss on this axis, followed by months since birth or age. And the purple line is showing you for babies that are symptomatic with regard to CMV infection at birth, that by school age, 5, 6, 7 years of age, approximately 40% of those infants may have cumulative hearing loss. But it's very important to note that for babies without symptoms, as shown by this green line, no symptoms at birth, that roughly 10 to 15%, depending on the data series that you evaluate, will have some hearing loss associated with CMV by the time they go to school. So again, screening is very important to identify these babies. This slide here is basically showing the clinical finding frequency is provided by the American Academy of Pediatrics. And so these are kind of an overview of all the signs and symptoms that babies can show us. And then it shows you the frequency. And so there are some things on here we didn't necessarily talk about, but these babies routinely will get what's referred to as a complete blood count with differential. We would look at the platelets because infants may have low platelets or thrombocytopenia. Babies may also have their hematocrit or their red blood cells be low, and may also have what's referred to as neutropenia or white cells be low. We've talked about some of the neuroimaging findings, the small head circumference, seizures. Some babies who do have seizures may undergo what's called a lumbar puncture or have spinal fluid obtained. And those babies can have abnormal spinal fluid findings. So just an overview of the frequency of these various findings that may occur in babies with CMV. This is a slide discussing the therapies for congenital CMV. And so approximately 20 years or so ago, ganciclovir was first studied in a national congenital antiviral study group at national children's hospitals across the country. And it evaluated ganciclovir. It's every 12 hours for 6 weeks. Okay, and basically this was a big deal for patients and families because if you can imagine, you just had a baby, you thought you were going to get to go home in 36 to 48 hours. You're told your baby has CMV. These babies needed to stay in the hospital so that we could maintain a long-term IV line. They needed to have drug monitoring and other things. So 6 weeks was a big to do. It's a big commitment to be in the hospital that long with your baby. This study evaluated babies that were moderately to severely symptomatic with regard to their central nervous system or their brain. And the outcome that was evaluated and found to be helpful with this therapy is ganciclovir decreases the progression of hearing loss. So you're unable to get any hearing back if the baby already had mild loss on one side. But basically, its claim to fame is decreasing the progression of hearing loss. Okay, and so several years later, people looked at valganciclovir. So some of the good things about valganciclovir is it could be given orally twice a day, which would allow people to transition to outpatient management, which means go home and be with their families. And the other good thing about valganciclovir is that at this dosing, 16 milligrams per kilo per dose, twice a day, same systemic exposure as the IV medicine, but less toxicity or less what we call bone marrow suppression. So these medications can decrease platelets or white blood cells, and this medication does it less than ganciclovir. And the more recent trial is published in 2015 New England Journal of Medicine, and that looked at the oral valganciclovir for not just 6 weeks, but extended it to 6 months. And so we see these babies once a month in our clinic. We increase the dosing based on their weight gain. And basically this trial showed that it improved hearing and neurodevelopment in the long term. Okay, so this is currently our standard of care in terms of what we do for babies with congenital CMV is that they usually are on oral valganciclovir for 6 months. If we have an infant who for some reason perhaps is in our neonatal ICU and unable to take the oral medicine, perhaps they've had surgery or some problem with their stomach or intestines, they would start on the IV therapy and transition to the oral therapy. Okay, so just as a reminder, we're trying to decrease the progression of hearing loss and improve their neurodevelopment. So in terms of anticipatory management, the primary care provider or pediatrician is very important to the care of these babies and families. And this slide here is provided by Pediatrics in Review, American Academy of Pediatrics, and it's the suggested follow-up plan for babies with congenital CMV. And you can see it's quite busy. Okay, it's a lot for families to coordinate, and with the help of their primary care, can kind of keep them on track for all the follow-up. I mentioned to you the audiology or the hearing evaluations, and over here you can see all the ages at which they will be recommended to have audiology screens. Ophthalmology also will follow these babies at birth, a year, 3 years, and preschool age. Often babies will be evaluated by neurology or developmental assessments, and they may require neuropsych referrals as well. Okay, so babies with seizures or developmental delays, infants with spasms may be followed by neurology as well. Okay. In addition, at our facility, we offer palliative care, and oftentimes people become quite anxious with palliative, that word, that perhaps the infant is going to die. And palliative care is really trying to find all the resources available for that family, inpatient or outpatient therapy, supportive services to maximize the baby's development, and also to help the parents and or family with childcare, with finding appropriate therapy locations for them. And so palliative will follow them both inpatient and or outpatient to kind of maximize their development and provide support to that family. Two programs that I very much appreciate in our state, and granted, they've largely been on hold for the last year due to COVID, but First Steps and HANDS. Many of you likely know that these are developmental screening programs. Before COVID, they would go into the home, which I think is great because it assesses the baby and family when they're most comfortable in the privacy and comfort of their own home, and see what they're capable of. They may also give families things to do, whether they be therapies or things to work on. So oftentimes that's easiest when they're in their own home. Just recently, I was talking to parents of a congenital CMV infant, and they were doing telehealth visits in their county. So I know many of the counties are getting back in some capacity, whether that be going into the home or doing telehealth visits and assessments. But these are programs which I think can really help our families. As you know, some families may have some barriers to care in terms of transportation or other things. And so if the program can go to the child and parents, that's wonderful in many regards. So as a reminder, CMV, we think this past year, roughly 36,000 infants per year in the US. There was an international CMV recommendations group that convened in 2015. They provided recommendation for prevention, diagnosis, and treatment. One of the things that they really emphasized is that we consider universal screening for early detection and intervention for sensory neural hearing loss and developmental delay. So this is the publication. If you're interested, it was published online in June 2017. It was published in real publication and paper in fall of 2017. And there are several of the authors that are national leaders here in the US listed, and it has been endorsed by our American Academy of Pediatrics Section of Infectious Disease Red Book. Okay, and again, just to emphasize, education, prevention, and consideration must be given to universal neonatal screening for CMV to facilitate early detection and intervention for sensory neural hearing loss and developmental delay where appropriate. So I'm going to end the talk by showing you kind of where we are in the United States in terms of who is screening for congenital CMV. This is from the National CMV Foundation, and the latest data is from March of this year. And as you likely know, Kentucky has advocated for universal screening of CMV. And basically, you can see across the states, they do vary from state to state in terms of what the legislation is. Utah has had legislation longstanding for CMV screening in their state. And then lastly, this is a slide, again, from the National CMV Foundation of birth hospitals who are screening. So here at Kentucky Children's Hospital, we are doing universal screening in our neonatal ICU, and we're doing a failed hearing initiative in the newborn nursery. And so with that, I'm happy to take any questions, and I look forward to the Q&A session that we're going to have with our panel. Thank you for your attention and your time.
Good afternoon. My name is Ken Iverson from the University of Kentucky. I'm the Chief of Pediatric Otolaryngology and an associate professor here. I have a special interest in hearing loss and treating children with hearing loss. Today, I'm going to speak specifically regarding congenital CMV and how it relates to hearing loss that we see in children. Hearing is a gift. It's a gift that allows us to hear and experience the soft sound of a mother's voice, a lively conversation with your best friends, the wonders of nature, or your favorite music. For every 1 in 200 babies born, there's a chance that CMV could actually rob a child of that gift. A gift that we know is not just a gift, but also essential for typical development for a child in his or her communication, speech and language skills, learning and understanding, and even safety. Hearing alarm bells, hearing fire engines, public safety vehicles. Very important in all aspects of life as a child. Now, Dr. Stadler spoke about what CMV is in great detail. However, just to review, CMV is cytomegalovirus, a virus causing the common cold very often. And this can affect 1 to 4% of pregnant mothers who can then transmit the virus to their baby. What does CMV do? Like I mentioned before, it can affect or infect 1 in 200 newborns. Most children seem asymptomatic, and I say seem asymptomatic because that's not necessarily the case, that I'll discuss later. But 10% of children with congenital CMV will have severe symptoms, including rash, yellowing of the skin, small head and brain, which affects growth and development, liver and blood problems, seizures, and also eye problems. Of those children who are infected with CMV prior to birth, 10 to 32% of them will actually have hearing loss. Half of children who have the symptomatic form of the infection at birth will develop hearing loss. And then surprisingly, 7 to 27%, depending on the study that is looked at, of those children who have, quote, asymptomatic CMV will have hearing loss. So as far as what CMV does, it infects and damages the delicate nerves and blood supply of the developing inner ear, or the cochlea, which is pictured here. This is a study in a mouse model of mice who have been infected with CMV while pregnant. CMV attacks delicate structures of the cochlea, which is the inner ear that is responsible for our hearing. On the left-hand side, this is a picture of the blood vessels of the cochlea that have been affected by CMV. And you can see that there is a less robust supply of blood to the cochlea in that model versus the one on the right, which is a mouse that has not been infected by CMV. So it very much affects the delicate inner ear structures. Most of the time, both ears are affected, but this can just occur on one side, one ear. And the scary thing, or one of the scary things, is that hearing can generally get worse, and this almost happens in 40%, almost half of children who have congenital CMV will lose their hearing even further later. And the majority of children will have profound hearing or end up having profound hearing. And what does that mean, to have profound hearing loss? Well, essentially, it means that in this range that we see from 90 to 120 decibels on the right, children will not be able to hear anything but sounds that are that loud. So normal sounds of speech, nature, conversation, things that are critical for development of speech and language, education, all those types of things can be missed out with the congenital CMV affecting the hearing. So again, this delayed hearing loss, as I mentioned, it can be a very scary thing. So some children can have normal hearing at birth, but can worsen later. Most of the time, it's going to worsen by 18 to 24 months of age, but even up to age 5, age 6, early grade school, we can find children who just now develop hearing loss from something they had from congenital CMV as a baby. And then in children who are symptomatic, up to 30% will have this delayed hearing loss as well. And then again, in those childs who are, quote, asymptomatic, so they don't appear to be affected by the virus at birth, they pass their newborn hearing test, these children can then go on to develop hearing loss that we discover later. And that is a common thing that I see in my clinic and my practice every day. So children are commonly being identified in preschool to early grade school with hearing loss associated with speech delay who pass their newborn hearing screen. And that, again, is a scary thing. And there are a lot of studies out there, this is one in particular, that have shown that CMV is now the most common identifiable cause of hearing loss in children, as you can see in this graph. So why do we care about this? Kentucky Early Hearing Detection and Intervention recommends for children with CMV to be tested every 3 months until they're age 3 years of age. And then after that, from age 3 to 6, to be tested every 6 months. Now, the challenge is if we don't know that they had CMV at birth, we don't know which children really to test. So that becomes a challenge. And it's important to have that early detection of the hearing loss because early detection means we can intervene early to help improve speech and language abilities, communication abilities, emotional and educational development. Interventions that we can afford are hearing aids that can be started shortly after birth once hearing loss is identified, so that children who are born with hearing impairment can have that immediate restoration of sound to help with their hearing and speech, because we do learn to start speaking as soon as we start hearing. So the sooner that we can have a child hear, the better they are going to learn to speak and communicate. We can provide speech therapy for children who are identified. In some situations, we can give medicine to newborns that can help slow the rate of hearing loss. And then also we have the ability to identify children who would need cochlear implants if they were to lose all their hearing. And we find that children who lose their hearing secondary to CMV actually do very well with cochlear implants if we can identify them early and track them along appropriately. So in Kentucky, we average about 50,000 births per year, which means we're going to have about 250 children born with congenital CMV. And currently there is no statewide method of testing for what we know to be the most common identifiable cause of hearing loss in children. CMV testing is actually pretty easy. We get some saliva, we get a urine sample that can detect the virus. It's very accurate, and we can feasibly identify every single child who is born with the virus or who has been infected with the virus. Universal screening for hearing actually already exists throughout the nation as well as in Kentucky, and we do a very good job with that. But as I mentioned before, in those children who have delayed hearing loss, a significant percentage of children with congenital CMV will develop hearing loss later, and those children will be missed. So if we propose to have universal CMV screening for all newborns in Kentucky, this could be a simple test that would identify every single child with the potential to develop significant global impairment from the virus, identify all children who would develop hearing loss from the most common identifiable cause of hearing loss, and work towards improving the health and well-being of children of the Commonwealth with regard to their speech and language, emotional, cognitive, educational, and social development. Thank you so much again for allowing me to speak on congenital hearing loss and as it relates to CMV in Kentucky and our hopes towards developing universal screening for children.
Hi, I'm Dr. Shelley Motes. I'm a pediatric audiologist and director of audiology with Little Ears Hearing Center at Open Arms Children's Health, which is located on the campus of Home of the Innocents in Louisville, Kentucky. And today I'm going to speak with you about hearing loss and congenital CMV infection. What we know today about CMV is that about 1 in 200 babies in the United States are born with congenital CMV infection. About 20% of those babies will have symptoms that impact their development and health, and 10 to 15% of babies with congenital CMV infection will develop hearing loss. And it's interesting to note that particularly for late acquired infections, particularly during the 3rd trimester in pregnancy, hearing loss is the only presenting sign or symptom of congenital CMV infection. Certainly, this is an area of interest for pediatric audiologists because we routinely evaluate and manage patients with congenital CMV. Hearing loss associated with congenital CMV can be congenital or present at birth. It can occur later in time. It can also be progressive in nature. So possibly start out as a mild hearing loss, and then over time, the degree of hearing loss can increase. CCMV associated hearing loss can also be unilateral or bilateral. The risk of progressive hearing loss requires that we as audiologists, first of all, know that infants are positive for congenital CCMV, and that is where the universal screening is so important. Oftentimes, especially if you have a baby where hearing loss is the only sign or symptom, you wouldn't necessarily know that they had CMV unless they had been screened and identified. We also need to closely monitor hearing for infants and children with confirmed congenital CMV infection. An interesting note for audiologists is that in many cases, we're the first provider besides a pediatrician that the family encounters with their newborn, particularly if the baby fails a newborn hearing screening. If the hearing loss is confirmed and a baby is less than 3 weeks old, audiologists should immediately refer to a pediatrician and discuss with them the importance of obtaining a CMV test as soon as possible. Ideally, that would take place before the 3rd week of life. We have a couple of guiding principles that help us know when to monitor hearing status in infants and children with confirmed CCMV infections. The first one is the Joint Committee on Infant Hearing Position Statement from 2019, which is comprised of many stakeholder groups that are interested in childhood onset hearing loss. The JCIH guidelines indicate that when a baby is diagnosed with congenital CMV infection, that baby should have a complete diagnostic audiology evaluation by 3 months of age. The JCIH guidelines go on to state that children with confirmed CCMV infection should be evaluated annually thereafter, or more frequently if there's provider or caregiver concern regarding hearing loss. In Kentucky, our EDDI group did a review of literature and determined that all babies in Kentucky with confirmed congenital CMV infection should be monitored every 3 months until age 3, every 6 months until age 6, and then annually thereafter. The difficulty is that the pattern of hearing loss with CCMV infection is not really predictable. For example, I recently saw a 14-year-old patient with congenital CMV infection whose hearing had been stable for a very long time. And then she suddenly lost the hearing in one ear and became a candidate for a cochlear implant, whereas before she had been a long-time hearing aid user since birth. So we can't always predict if the hearing loss is going to progress, and if it does, when or how rapidly. So routine monitoring is extremely important with this population. Another recent patient encounter with a 6-year-old had a decrease of 30 decibels in her hearing in a 6-month period. So progression of hearing loss with CMV can be very rapid, which was the reason for our Kentucky Early Hearing Detection and Intervention Group establishing slightly more rigorous guidelines than what was recommended by the JCIH to monitor hearing in children with congenital CMV. So for audiologists, the components of an evaluation for infants should include a case history, otoscopic examination, or looking in the ear, evaluation of the middle ear system to include tympanometry and acoustic reflexes or wideband reflectance test. This helps us to evaluate the health of the middle ear and how that might be impacting hearing status. We look at otoacoustic emissions, which is a test of sensory cells in the cochlea to help us determine if those cells are functioning normally. And then finally, we use auditory brainstem response, or ABR, to estimate hearing levels by frequency. And in the event that an infant has hearing loss from congenital CMV, this allows us to quickly and accurately provide hearing aids that are fit appropriately so that the child has good access to communication. For toddlers and up, a lot of the components are the same, but as children get older, instead of doing an objective test like ABR, where the child does not have to provide any kind of response, and we estimate the audiogram, if children are older and developmentally able to do so, we use testing where the child responds in some way when they hear a sound, whether it's to a visual reinforcer, whether they're holding a block in their hand and dropping it in the bucket when they hear the sound, or for school-age children, just simply raising their hand when they hear a sound. And the infant and toddler breakup in terms of what's needed is just a guideline. Generally, audiologists are selecting the testing that they do, not only based on the patient's age, but also on their developmental status. And JCIH guidelines do recommend that if a decrease in hearing is suspected before age 3, even if we are using behavioral testing to evaluate that child, that confirmatory ABR testing is needed to document any decrease. There are some really great references available. If you would like to learn more about congenital CMV infection, you can visit the National CMV Foundation's website at www.nationalcmv.org. To learn more about audiology recommendations for testing, you can visit the Joint Committee on Infant Hearing website at www.jcih.org, or you can always visit the CDC website, as they have a specific section of their website devoted to congenital CMV. Thanks for being with us today, and we hope you found this informational.
Hello, my name is Julia Stevens. I am a professor in the departments of ophthalmology and pediatrics at the University of Kentucky College of Medicine. And today I'd like to share with you a few details about eye findings in children with congenital cytomegalovirus, or CMV. And I will continue to refer to this as CMV throughout the rest of the talk, because as we all know, cytomegalovirus is quite a mouthful. So just to talk a little bit about the vision impairment in children with congenital CMV, about 18% of children who have symptomatic congenital CMV will develop severe visual impairment. And these vision impairment causes are listed below here. So the most common one is what is termed chorioretinitis, which is an inflammation in the tissues that line the back of the eye. The second most common is optic nerve atrophy, or damage to the optic nerve for eyesight. And then also, due to the other consequences of CMV in the central nervous system, these patients can also develop cortical visual impairment, which is damage to the visual pathways in the brain for eyesight. Other eye findings that can be seen in children with congenital CMV include nystagmus, which is a rhythmic movement of the eyes back and forth, strabismus, where the eyes are misaligned, and very rarely cataracts as well. Treatment for the CMV chorioretinitis, which is typically seen in infancy, is with an antiviral agent, the most common being ganciclovir. And in the photographs here, the top photos are showing a picture of the retina. We're seeing the optic nerve looking rather pale here, and we can see these areas of whitening here, these large areas which look rather opacified or white, are areas of active retinitis or inflammation of the retina. And this bottom two photographs are showing the residual scarring of the retina after treatment. And you can see these large areas where the retina is damaged. You can see the pigment clumping in those tissues there. And again, the paleness of the optic nerve is indicative of optic nerve atrophy. So vision impairment, again, is more common in patients who have other systemic findings of CMV, the rash, jaundice, small head circumference, low birth weight, and large liver and spleen and seizures. So when we see that the eye findings, typically these children are going to have other manifestations of CMV. Visual impairment is especially common in children who have a history of congenital CMV and who also have developed the sensory neural hearing loss, which is associated with CMV. And as you know, that is one of the devastating features of this virus, is that it causes damage to both hearing and eyesight, which leaves these children with multiple disabilities. Infants who have a positive CMV test by serology but are otherwise asymptomatic rarely develop any visual findings or visual sequelae. Another important point is that unlike children who develop neurosensory hearing loss from CMV, who may show progressive hearing loss later in life and need to have long-term follow-up because of the chance of progression, children who have the chorioretinitis from congenital CMV typically do not show any signs of progression. So the vision damage that is caused by the retinitis and the optic nerve atrophy remains stable throughout the rest of their life. Children with symptomatic CMV who do not experience vision issues in infancy also have no increased risk of vision problems later in childhood or adulthood. So if they develop the other signs of CMV but have no evidence of chorioretinitis or optic nerve atrophy in infancy, they are unlikely to develop those later and therefore can maintain the same level of visual acuity of any other child as they grow up. So because of the nature of how CMV affects the eyes, in terms of screening exams, we recommend that for any child who has eye findings or vision disorders from CMV in infancy, yearly exams or more frequent as indicated for treatment of their eye conditions are recommended. Asymptomatic children who have no other findings from CMV, but those who did have a positive test for CMV need to receive a baseline eye examination and then eye examinations as needed. Sometimes there can be some subtle findings in the back of the eye that are not visible without a complete eye examination. So they still should have a complete exam, even if they do not show any signs of vision compromise. And as I mentioned before, many children with congenital CMV will have multiple disabilities and will require an eye care provider as a part of their medical team throughout childhood. Those with significant vision impairment will require special services, which can be provided through other agencies that work with children with visual impairment throughout childhood, and also in school. They will need to have those types of services as well. Thank you very much for allowing me to be a part of this presentation, and I hope you have a great day.
Good afternoon. My name is Arpita Lakotia. I'm a child neurologist at University of Louisville Northern Children's Medical Group. Thank you for inviting me to talk about the neurologic manifestations of congenital CMV. Just moving right along. So as a lot of people have already talked about, cytomegalovirus is the most common cause of congenital viral infection in the Western world. And it's the leading cause of non-genetic hearing loss in infants born in the US. And about 10 to 20% of children who are born with congenital CMV show signs of neurologic damage at follow-up. With CMV is a double-stranded DNA virus. It's in the herpes family viral group. And typically in pregnancy, you can have infection or reactivation of the virus to cause the disease in the fetus. In utero, CMV can affect the brain at any stage of neurodevelopment, and that's what makes it very dangerous. In early pregnancy, if the infection happens or if reactivation happens, it has teratogenic potential, meaning it has potential to affect the development of the fetus. If it is within the first 12 to 24 weeks gestation, it can cause neuronal migration defects. What that means is that when your brain cells are forming, it can affect the formation of the brain structure as well as organization of the brain, parts of the brain essentially. And viral proliferation can impede the proliferation and differentiation of the brain stem cells. If CMV infection happens later in pregnancy, typically that part of neurodevelopment has already happened where your brain structure is already formed. Now you end up seeing more of a destructive process, especially in the white matter of the brain where you have white matter abnormalities, but you don't see those typical migration defects, which are typically affecting the brain cell structure. Because of either of these changes, congenital CMV infection can cause issues such as neurodevelopmental disorders such as cerebral palsy, as well as epilepsy. So early neurological manifestations that may be seen in association with congenital CMV, of course, the most severe ones are having a miscarriage or stillbirth if it is early on in pregnancy. Aside from that, things like IUGR, which is growth restriction of the fetus, is very, very common. Having a small head size or microcephaly is something that is common, and it is associated with basically neurological sequelae or poor neurological outcome. Babies who have neurologic involvement with congenital CMV may have seizures, low tone, lethargy, and then other things such as sensorineural hearing loss, as well as vision loss affecting the vision can also happen, which are again mediated by the neurological system. So over 60% of patients who have symptomatic congenital CMV may have abnormalities in their brain. The severity of this brain abnormality may vary from mild abnormalities to more severe abnormalities, as well as whether it's affecting more neuronal migration or the gray matter of the brain, or it is affecting the white matter of the brain. Because of the neuron, specifically because of neuronal migration defects, epilepsy is very common in association with congenital CMV. And really, the epilepsy can be fairly severe. It all depends on how severe the brain malformations are. And these seizures can be quite refractory to treatment. And related to congenital CMV, again, based on what the brain malformations are, there can be different kinds of seizures that may be seen, which may range from the milder forms such as focal seizures to more infantile or epileptic spasms. And as the child grows older, may actually lead to development of Lennox-Gastaut syndrome, which is a epileptic encephalopathy, meaning it, again, in relation to the seizures, also you can have a delay and regression of your development. In terms of brain abnormality, again, looking at this picture, this is an MRI of the brain, and just looking at this brain, there are many abnormalities that I can see on here. One of the things is that this is the gray matter of the brain, and the appearance of this gray matter, the cortex here, appears pretty lumpy, bumpy. Overall, it does not look normal throughout the brain. This is something called polymicrogyria, which is a form of neuronal migration defect. So this would be something that is seen if the congenital CMV infection happens early on in utero. Other things that we can see are that the white matter of the brain right here looks quite abnormal, and might have to take my word for it because it does look abnormal. There's nothing to compare it to anything. The third thing that we also see, the fluid spaces of the brain or the ventricles look bigger than what I would expect to see in an infant, which is certainly something that can be seen in association with congenital CMV. Other forms of brain abnormalities in terms of neuronal migration defects that can be seen aside from polymicrogyria would be pachygyria, which is a thick gray matter cortex, as well as schizencephaly, which is a cleft in the brain. All these three are forms of just cortical brain malformations, which are related to neuronal migration defect. Again, in later pregnancy, you can see white matter abnormalities. Other non-specific things that could be seen are brain atrophy, brain calcifications, as well as bigger ventricles. So in general, in terms of neurological manifestations, other things that overall can be seen in association with congenital CMV, neurodevelopmental disorders are very common, and this may include delayed development in all domains, whether it is gross motor, fine motor, speech, social, or cognitive. And as a child grows older, you may see intellectual disability, which all may culminate into cerebral palsy. And again, cerebral palsy is just a term that we use to describe abnormalities in the brain, in the developing brain that may lead to motor manifestations. But in association with congenital CMV, CP may be anywhere from the mild to severe end of the spectrum. It all really depends on how much brain damage there has happened. And of course, in very severe cases with congenital CMV, death may be seen, whether that is related to complications of epilepsy, such as pneumonia or infection or sepsis. In terms of how much neurological involvement there might be, there are certain things that can help predict this even from early on. About 10-20% who have congenital CMV, whether they stay symptomatic or they stay asymptomatic or they're symptomatic, will show some signs of neurological involvement when they're seen at follow-up. If it's a newborn that's being seen, the most important predictors for brain involvement may be, one is if they have symptomatic congenital CMV at birth. About 1/3 of these patients, about 2/3 of these patients may have neurologic sequelae, which goes with 60% of patients will have this. If their head size is small, or if they have microcephaly, or if if we do brain MRI and there are abnormal brain imaging findings in the first month of life. These would be the three most important predictors of which are the children who are going to have neurologic sequelae. Looking at the picture on the left this is a CT scan of the brain. And here, these bright spots that can be seen in the back portion of the brain, these show calcification, which is another thing that can be seen in association with congenital CMV. In terms of neurologic follow-up, really the most important thing is any child who is diagnosed with congenital CMV, whether or not they have neurologic manifestations, monitoring their milestones and monitoring their neuroexam over time is extremely important. If there are any concerns of CNS or brain involvement, referral for early intervention services, such as first steps, is absolutely important because that gives you a set of eyes who's also taking a look at how the child is developing. And if there are any concerns that pop up from a development standpoint, they can be referred to child neurology. If the parents should be counseled about what seizures can look like and the risk for seizures, and basically giving them proactive instructions on what to monitor for and what to reach out to their physician for is absolutely important. And nowadays we use this a lot. Almost everyone has a camera with a cell phone camera with video. So if they see anything that looks concerning for seizures and the parents are not sure whether it's a seizure or not, they can always videotape it and share with their healthcare team. If there are any concerns from a development standpoint or from a seizure standpoint, prompt referral to neurologist is absolutely important. Because if there are any clinical concerns, we may perform neuroimaging with a brain MRI. And if there are concerns for seizures, they may need EEG recording of the brain. And then if there truly are seizures, those would need prompt management, because if seizures go untreated, they can not only cause further regression of milestones and development, they can also put the child at risk for sudden death. So really for congenital CMV from a neurologic standpoint, management is just management of symptoms. There is no specific drug or therapy that treats the manifestations associated with congenital CMV from a brain standpoint, but just again, early intervention from a therapy standpoint, treatment of seizures, being proactive about telling the family about what to look out from a seizure standpoint is absolutely important. Assessing for hearing and vision impairment, and if there are any concerns, making sure that appropriate management measures are in place, whether it's seeing an ophthalmologist or seeing an audiologist or an ENT physician, or needing glasses, hearing aids, other communication devices. If there are cerebral palsy symptoms, just symptomatic management of those, whether that is through muscle relaxants such as baclofen, need of Botox, or need of surgery such as SVR, or just needing bracing equipment like SMOs, AFOs, wheelchair, medical strollers, other adaptive equipment is important. And what is required for each child will really vary from child to child, and it has to be an individualized plan based on what the deficits are and what needs to be addressed. And as the child grows older, certainly working with the school system in terms of what sort of assistance is needed, whether it's a 504 or an IEP or both. And then as the child grows older, a neuropsych evaluation may be helpful as well. But really, it all comes down to just management of symptoms that are being seen. So again, this is from the National CMV Foundation. There is a huge spectrum of what can be seen with congenital CMV. From left to right is from most severe to the mildest form, where you may have things such as death, miscarriage, stillbirth, to where you might have a child who has no visible delays or impairment. And thank you for your time. I'm happy to take any questions.
Good afternoon. My name is Dan Stewart. I'm a fellow of the American Academy of Pediatrics. I'm a professor of pediatrics and international pediatrics at Norton Children's Hospital and the University of Louisville School of Medicine. I'm the medical director of the EGMA program here at Norton Children's Hospital. I've been the director of our neonatal intensive care unit, which is a level 4, for approximately 20 years, recently stepping down from that role. So today I have the privilege of talking to you about universal screening for congenital cytomegalovirus. Okay, so to start out with, to talk about universal screening for congenital CMV. So there's both maternal primary and non-primary CMV infection. So primary means that the mother acquired a CMV infection during pregnancy. Non-primary is that she was tested negative for CMV, but she passes this on to her fetus. It's thought that this might represent a reactivation of a latent CMV infection, or perhaps she acquired a different strand. So if the mother has it during pregnancy, this can result in utero transmission to the developing fetus. And as you've heard in other reports, congenital CMV results in significant morbidity, mortality, and certainly long-term sequelae. Sensory neural hearing loss is the most common of these serious sequelae. And then less frequent, but certainly as severe long-term sequelae include vision loss from chorioretinitis, cognitive delay, as well as motor delay or cerebral palsy. So CMV too is really one of the leading congenital infections worldwide. So congenital CMV infection meets many of the criteria for screening, allowing for early detection and intervention to improve clinical outcomes. This is very similar to when the state of Kentucky approved universal newborn hearing screening. So what are the criteria for universal screening program? Well, you've got to evaluate the incidence, the disease, as well as the prevalence. The incidence is how many new cases have been diagnosed, but prevalence is how much exists in society. So we look at both the incidence as well as the prevalence of a disease or condition. And then diagnosis. Do we have a reliable way of making the diagnosis? This has evolved, as I will talk about in some subsequent slides, over the last few years. And I think we're at a point now where we can reliably make the diagnosis. And then is there treatment available? Well, certainly they are. So antiviral agents are now available. Speech language therapy is also available, as well as cochlear implants. And then another facet that's got to be considered is the cost effectiveness and the burden of the disease. And as you will hear in some parental presentations, the emotional cost to the family is part of the burden of the disease. So let's go back and talk a little bit about the incidence of the disease. So in the US, Canada, Western Europe, and Australia, the incidence is about 5 to 7 per thousand. In the US, in the Black population, it's about 10 to 12 per thousand. So around 1% or slightly greater than 1%. In some of the other foreign countries, such as Latin America and Africa, the incidence may be as high as 10 to 30 per thousand. So you can see that it is the most common congenital viral infection, and it has some very significant downstream sequelae. So now, what about universal screening for cytomegalovirus? Currently, there are no universal programs that offer maternal or neonatal screening to identify infected mothers and infants. So there's some in development, but there's no universal programs. Most obstetricians do not screen for CMV unless the mother has a mono-like illness, infectious mononucleosis, or if she specifically requests to be tested for CMV. And neonatal screening obviously is gaining a momentum. Well, what about vaccines to prevent the infection? Well, there have been several trials of maternal vaccines to prevent the infection without success to this point, and there's an ongoing study at the present time. So no efficacious and safe therapy are available for the treatment of maternal or fetal CMV. So if the mother has CMV or the fetus, not the newborn, but the fetus, there is no available treatment at this time, but hopefully that will evolve with time. And then at the present time, certainly if we have a baby born in our NICU who has CMV, We can treat them with ganciclovir and then send them home on oral ganciclovir for maybe a 6-month period as indicated for symptomatic infants with CNS involvement or central nervous system involvement. And as you've heard in previous presentations, about 10% of babies will be born symptomatic at birth, but about 90% are asymptomatic at birth. So without screening, we're not going to detect those babies. Unfortunately, the ones that come to the neonatal intensive care unit often have extensive involvement in all organ systems, and we've seen many of those over the years. So data has now shown that there are several maternal and neonatal strategies for screening. So what should be our screening approach? Well, certainly targeted is what we do at Norton Children's Hospital. What do we mean by targeted screening? Well, testing the infants that refer or fell, we're now allowed to say that they fell on their AABR, or the auditory brainstem evoked response, on hearing screen. So if they fell, then these babies are then tested for CMV. But unfortunately, a large randomized controlled trial of the babies who had failed their newborn screen or their AABR actually showed that only 57% of them were detected to have CMV. So you can see that even if you test those that fail, it may only pick up, close to 60% of those infants with CMV. What about using the dried blood spots? Well, as you may well be aware, that's been tried in the past, but it has low sensitivity, so it's not very sensitive or specific. So what is available? Well, universal screening. Well, 2 types of universal screening is you could use urinary CMV PCR, or you could use saliva. If we use urinary CMV PCR, it's very difficult to collect, and sometimes it delays discharge, et cetera. So much more expediently is the salivary CMV PCR. So universal screening, so diagnostic methodologies are now available that allow for the identification of those infants at risk of developing sequelae and adequately detect the congenital CMV infection. So salivary CMV PCR has greater than 97% sensitivity. And it is recommended that if you get a baby who tests positive on the salivary CMV, that's confirmed with a urinary CMV PCR. Well, are there future goals to prevent congenital CMV and to improve outcomes? Well, certainly there is an opportunity for this. So well-designed clinical trials need to be developed that address several facets of CMV treatment. So in other words, pregnant women. Obviously, a lot of work is being done on vaccine. Maybe there's additional antiviral therapies that we could give the mother who is pregnant and diagnosed with CMV. What about the CMV infected fetuses? Likewise, maybe other medications or other therapies such as hyperimmune globulin against CMV could be given to the fetus. And certainly symptomatic neonates and children. So right now we use valganciclovir, but are there other antiviral therapies that might be more efficient and have less toxicities? And then the elephant in the room is the asymptomatic neonates and children, because as we said, approximately 90% of babies are asymptomatic at birth, but yet almost around 1% of babies are positive for CMV. So we need to have a good strategy for exactly how these infants are going to be managed and followed. It's because of the asymptomatic infants, about 10 to 15% of these patients develop sensory neural hearing loss. And obviously, we have to worry about these infants developing progressive hearing loss with time. So these infants, if diagnosed, could be certainly earmarked for additional testing. So, and then can we prevent it? Well, future goals to prevent congenital CMV. All of the following demand further exploration to fully realize the ultimate goal of preventing congenital CMV. As we've talked about, prevention with vaccines, to clarify the biology and the transmission factors that are associated with the non-primary CMV infection. You know, the primary is easy to explain, the biology and the transmission, but the non-primary, we need further clarification if this is a reactivation or maybe it's acquiring a different strand of CMV. And then we need to further analyze the cost effectiveness of universal screening. There's been many publications showing that universal screening is cost effective. And then this may surprise some of the audience, but prevention of primary infection during pregnancy should be championed to all by means of hygiene education to mothers, hand washing with water and soap, plus not kissing the infant in or near the mouth, or putting objects or food into your mouth and then giving it to your child. And there was a recent health survey in 2015 to 2016 in Health Styles that showed maternal awareness is extremely low about CMV in the US, with only about 9% of mothers possessing knowledge of CMV in a health survey in that 2015-16 Health Styles survey. So, conclusion. Is it time for congenital CMV screening? Considering the prevalence of the disease, again, it's more than 1%, and in some countries in Africa, et cetera, it may be 3%. Are we able to diagnose with minimally invasive testing with a high degree of sensitivity, greater than 97% with a salivary PCR? And then treatments. So certainly are available to ameliorate the condition with antiviral medications, speech language therapy, and even cochlear implants as needed. And then there's also emotional support organizations to help parents and children who are diagnosed with congenital CMV. And again, to validate the cost effectiveness of congenital CMV screening. This was a big issue when we got universal newborn hearing screening passed, but it's obviously nationwide now. And this is really before the board of the American Academy of Pediatrics. They're considering having a nationwide approval of universal screening for CMV. So I will close with this thought. If it were your child or your grandchild, I think that you would certainly agree that it's time for universal testing for congenital CMV is upon us. So thank you for your attention, and we'll close with that. Thank you.
We have now completed the academic portion of our webinar. Now let us move to the second part of our webinar, where you will meet families and children with CMV and see the toll this illness takes on these families.
Hi, everyone, and thank you for joining me. My name is Amanda Devereaux, and I am the Program Director at the National CMV Foundation. I am also a CMV parent, and I'm so excited to be here today and talk to you a little bit about the work that we do at National CMV. And I'd like to start with this video of a sweet little girl named Caitlin. And I think that her and her family's story is a really good representation of what the impact of CMV is and what CMV families oftentimes experience.
Okay, ready?
Yep. Tell me about yourself. Tell me about you.
I'm Caitlin Gill, and I love to play.
Caitlin is my second child, and my first pregnancy was so easy.
A couple of ultrasounds before Caitlin was born, there were things happening medically, with the ultrasounds that made us nervous.
And I just assumed when they said, well, we've got this problem, but this one cleared up, that it really wasn't that big of a deal.
I always felt a little bit left down in that way, that we didn't have a whole lot of information. Nobody said, hey, this is actually a big deal. Your baby could be in danger. I don't know if they wanted to protect our feelings or what, but it seems like it was underplayed a little bit.
She was quiet when she was first born. They did a C-section and they had her, and we kept waiting for that cry. And we did hear it, but it was little.
She was 4 pounds 10 ounces, so she was very small. She had all these health issues.
It's really common. It's the most common congenital virus.
When I know somebody's pregnant, I always say, hey, do you know about CMV? And they almost always say no.
I would like it to be just another thing that women know about, something that women know to avoid. So I'm educated, I know about CMV, and I still got told, oh, it's not ever going to happen again. It's so rare. Your case was kind of isolated, and it's not rare. It's pretty common, and they're just not getting the education that they deserve. I didn't think that, 7 years down the road, we would still be in speech therapy and going to doctor's appointments and dealing with effects of this one virus that caused so much damage.
I was born being really sick. And then somehow I was getting deaf. So when I was at least 4, I got my hearing aid.
So now she is 7 and she is completely deaf in her right ear, and she's got a moderate loss in her left ear. And so she uses a cochlear implant on the right side and a hearing aid on the left side.
I'm pretty happy that Jesus made me up with my mom because I don't get in trouble a lot.
She doesn't see those kind of dividing lines that we see. Everybody's her friend. It doesn't matter who they are, how they look, how old they are. They're all her friend, and she's so open and she's so happy, and she'll give anybody a hug. And when she grows up, she wants to bake cookies and give them to people. And that's just Caitlin. She just is loving.
And nobody knew what it was, but I wish we'd been given a little bit more information.
It's not hard. It does take a little bit of a shift and some intentional behavior, but you do that all the time when you're pregnant anyways. And you're accustomed to that. You understand the importance. And I think that moms are willing to do anything to protect their kids as long as they know about it.
I love how I am. I am a perfect girl. I have a perfect home, perfect mom and dad, and most of all, perfect sisters and brothers. I am the perfect girl in my family. I'm a little too perfect from the others because they are not there. So, too bad for them.
I love that video, and I think it's just a great way to get started and introduce this topic. So for our discussion points today, we're going to talk just a very, very brief little bit about what is CMV and what is congenital CMV. I don't want to repeat too much of what everybody has already heard in the other presentations, but we'll just very briefly go over that. We'll also talk a little bit about what we do at the National CMV Foundation and how we impact the space and how we help families. I want to talk a little bit about the current state of screening for congenital CMV in the United States, and then introduce the topic of what families who receive a congenital CMV diagnosis experience. So I'm going to start actually with my own story. As I said, I'm a congenital CMV mom myself. My daughter, Pippa, is going to be 6 in the fall. And so her journey and our journey really started nearly 6 years, well, actually about 6 years ago, almost exactly. In June of that year, I was at my 20-week ultrasound, and that is when we realized that there were abnormalities on the ultrasound. And so this was a planned second pregnancy for us. And I don't share that to just share too much information with people, but I like to share that piece of it because this was really a missed opportunity. We were in for fertility treatment, and we were in making sure that we were doing everything that we could to, number one, get pregnant, but also to ensure a healthy pregnancy. And nobody ever mentioned congenital CMV to us, even though we had a toddler in daycare at the time. So that's just a really big missed opportunity in our case. And so we were at the 20-week ultrasound, and we saw some things on the ultrasound that were concerning. And so we decided to do an amniocentesis to figure out exactly what was going on with our baby. And so, first of all, that procedure is I mean, it was very upsetting, both emotionally and then physically too. It's uncomfortable, and then also just knowing that there's a small risk of harm with that procedure was a difficult thing to go through. And then just the wait afterwards until we finally got the news that Kiba had congenital CMV. That was a very, very hard time, and just knowing that we would have to go through the rest of the pregnancy, not knowing what things were going to happen and how it was going to turn out. And so our doctors at the time told us there's nothing you can do. They said you can terminate the pregnancy or you can do nothing and just see what happens. And they had no way to really predict what the outcome would be. So people who know me know that I'm not really a sit and do nothing kind of person when it comes to my kids and their health. So we did our own research. We tried to find a CMV expert in our area. I live in Iowa. And so we found in Minnesota, a neighboring state, an expert at the University of Minnesota. And we were able to connect with him, Dr. Mark Schleiss. We always love to give him a shout out because he really helped us so much during that time when we didn't have very good information. And so he was able to connect us with the maternal fetal medicine specialists up at the University of Minnesota. And they helped us arrange immunoglobulin treatments during the pregnancy. And so we've received 4 treatments of cytogam, it's called, during the pregnancy. And this was experimental treatment, but at the time we were told that it might help, but it shouldn't hurt. And so we felt like this was something worth doing because we wanted to do anything that we could to try and help our baby. And insurance did cover the treatment, and the treatments were about $20,000 a piece. So we had $80,000 worth of treatment covered by insurance during the pregnancy. When Pippa was born, she was delivered at 34 weeks, not due to congenital CMV, just because she had stopped moving, and so they had to get her out. She was tested for CCMV and she had CMV in her blood, urine, and saliva. So she definitely had CMV everywhere, I guess you could say, when she was born. But she really looked the picture of health. If we hadn't seen those small abnormalities on ultrasound and she had been born, I don't know that anyone would have realized that she had pretty significant consequences from the congenital CMV. Symptoms at birth were thrombocytopenia and intracranial calcifications. But again, things that you really couldn't see from the outside on like a general newborn exam. So she was in the hospital for 3 weeks in the NICU just because she needed to learn how to feed and grow. She really was doing pretty well in terms of the CMV side of things. She did receive valganciclovir or Valcyte orally twice daily for 6 months. That was covered by insurance. And she had lots of follow-ups. She saw audiology frequently, had vision checks frequently. We had early access or early intervention right away. And that's an automatic qualifier in our state and many states. Congenital CMV is an automatic qualifier for early intervention in a lot of places. So she went to the developmental clinic. She had to see infectious disease doctors. She's seen PT, OT, speech, and feeding. She's kind of seen everybody. And so she's gotten a lot of help and we're happy with how she's doing, but she is pretty significantly impacted. Currently, her diagnoses are polymicrogyria. So that's a brain malformation. When I had my CMV infection, it was probably sometime during the first trimester. And so when Pippa's brain was forming, it did not form typically. And she doesn't have the nice deep folds in her brain that we usually see. She has kind of smaller folds all over her brain. And so that definitely impacts her developmentally and intellectually. She has a developmental delay, intellectual disability. She also has seizures from the brain malformation. She's nonverbal. She uses a little talking device, which she's working on, and she makes good progress with that. But communication is still a huge issue for her and for us. She does have issues with feeding. She's always been okay with her bottle, but solid foods are a struggle. She can have purees, and then we actually have a feeding tube for when she's sick. She gets dehydrated really easily, and then we always give her meds through the tube too, just to make sure that she gets them all. And then she does have hearing loss, but interestingly and importantly, She did not have any hearing loss until age 3.5. So this is just a good reminder, and I think other people have already said this, that those hearing follow-ups are extremely important because you never know when the hearing loss is going to show up. So right now she has mild on one side and mild to moderate on the other side. So she wears bilateral hearing aids. And she's the sweetest little thing ever. And she has incurable cuteness. It's pretty severe, the cuteness that that she brings to our lives. So we're very happy to have her, and we're so happy that she's doing as well as she is. So what is congenital CMV? Just a very, very brief explanation. I know others have covered this, but when an expectant mother catches CMV, the virus can cross the placenta and infect the developing baby. So when a baby is infected with CMV before birth, it's called congenital CMV. We abbreviate that CCMV. Overall, 1 in 200 infants are born with the virus, and 1 in 5 of those infants will have a birth defect or a permanent health condition. So that translates to 1 out of every 1,000 births in the United States are going to have a birth defect or permanent health condition from congenital CMV. This is the most common infectious cause of birth defects and arguably one of the most common causes of birth defects, period, in general. So others have talked about this a little bit too, but there is a spectrum of symptoms, and we'll hear this from some of our families and hear exactly how their children have been impacted. But some children are born with no symptoms and they're never going to have any symptoms. And that's what we hope for, and that's what we want. But some children are going to be born with subtle symptoms. Some are going to be born with severe symptoms. And then some children are going to unfortunately die before birth, stillbirth, miscarriage, or die after birth, just from all the complications arising from the virus. So sometimes it's hard for me to decide where to assign Pippa on this spectrum. But I would say she's somewhere between moderate and severe. She definitely has a lot of things going on. We're fortunate that she's mobile. She is able to walk, however unsteady she is. We're very grateful for that. And she started walking at about age 2.5. But she does have significant motor delays, the intellectual disability, hearing loss, seizures, all those things. So definitely somewhere on the moderate to severe end of the spectrum. So how big of a deal is this, and do people know about it? Well, it's a big deal, and no, people don't know about it, unfortunately. So this graph made by Dr. Kathleen Muldoon really shows how big of a deal this is compared to how aware people are. So if we look at the orange dots are the number of children disabled by the condition every year. So if we look down at Down syndrome, the orange dot around 6,000, and then the blue bar is the awareness, the percent of women who've heard of the disease or disorder. And so we see that Down syndrome, the awareness kind of matches the incidence or the number of children impacted per year. But then if we look at congenital CMV, we see the orange dot around 6,000 children permanently disabled by the condition each year. And then that scary little blue bar over there is the number of women who've heard of it, the percent of women, and it's about 9%. So this is what we call the awareness gap, something very common that few people have heard of, and we really don't want that. There's that gap there, and we need to fix that. So what do we do about it? Well, there's lots of things to do. We at the foundation advocate for a lot of different things, vaccines, screening, awareness, education, prevention, all sorts of things like that. And currently there's no vaccine licensed. So we really want women to practice simple tips to help prevent CMV, which is difficult when women haven't heard of it. So we have the 5 simple tips. Avoid contact with saliva when kissing a child. To us, that means maybe kissing a kid on the forehead instead of on the lips, or even on the cheeks. If they're a little kid and they're drooling a lot, the cheeks might have some saliva on there too. So really maybe kissing them on the forehead or giving them a nice big hug. We certainly aren't advocating for people to stay away from their children. We just want people to be a little bit more careful than they normally would be. Do not put a pacifier in your mouth. Do not share food, utensils, drinks, or straws. do not share a toothbrush, and wash your hands after changing a diaper. And sometimes people say, well, these things are obvious. And of course, I always tell my patients to practice good hygiene during the pregnancy. And my response to that is usually, well, of course, these are things that people should know. But when you're a busy mom and you're pregnant and maybe you've got a toddler at home or you're working with toddlers, it's easy to forget these things, especially when you don't know that there's a significant consequence attached. So I remember doing these things when I was pregnant, and I had no idea. You know, my son would finish half of his breakfast, and I think, oh, I'll just finish that because I don't want to waste the food. And you think nothing of it, and you don't realize that that's really a significant choice that you're making. And so I think if we can get people to just think about these things and take these extra steps, it can make a huge difference. And women really want to do whatever they can to protect their pregnancies. So I think that these are easy tips that pregnant women can work on. So what do we do at the National CMV Foundation? Well, our mission, we just recently updated our mission, and the new mission is to prevent pregnancy loss, childhood death, and disability due to congenital CMV. And who we are, we're parents, scientists, and activists guided by leadership, passion, innovation, excellence, and integrity. And we're working collaboratively to stop CMV. So we're all working together. We have the same goal. There's a lot of ways to impact CMV and the current state of congenital CMV in the United States. And so we try to have as big of a reach as we can, even though we're kind of a small organization. We have 2 full-time staff members, and then we have a vast number of volunteers and a 9-member board and a scientific advisory committee and other committees too that support our work. And of course, we have all of our fantastic parents and volunteers that help and spread our message. These are our strategic goals, which were recently updated. So we really tried to advocate for prevention, screening, tracking of congenital CMV. We do provide research awards, so we really want to focus on cutting edge research that really is going to make an impact on the state of congenital CMV. How can we get a vaccine? How can we have pregnant women prevent this through behavioral measures? How can we detect this early, and how can we treat it? We want to target our education programs to women, families, healthcare providers, and policymakers so that people can make informed decisions and hopefully, enact policies that are going to help us reach our goals. We work to grow resources in support of the mission. Just like all nonprofits, we can't do it without raising funds. So we do raise funds to support our work. We have great volunteers that fundraise for us, and we're always so happy because that money goes back to the mission and helps fund the research awards and some of the other programs that we have. And then we've added a new section to our goals, and we really want to focus on diversity, equity, and inclusion. We know that there are health disparities related to congenital CMV, and we know that we need more information and more research on that topic. So we really want to make sure that we are working to address those issues. One of our programs that I wanted to highlight here today is called our CMV Community Alliance. And this is a current map, but I'm hoping it's going to actually get a little more colorful even in the next couple of days here. So we have 18 currently dedicated CMV Community Alliance chairs in 16 states. Some states are lucky enough to have 2. And so these wonderful volunteers are parents or advocates who just really recognize the importance of congenital CMV and who want to volunteer and spend some of their time on trying to make a difference. So they're doing so many different things, and it's hard to include everything that they're doing here, but they're doing speaking engagements and they're hosting events as able, and hopefully as things start opening up after and at the end, hopefully here of COVID, we'll be having even more in-person events. They're serving on state work groups to provide either the parent or advocate perspective. They're advocating for CMV legislation. And last year, this group of volunteers raised over $18,000 to support our programs. So these people are working really hard, and there's a lot of states that don't have someone yet. So if there are people out there interested in this, they can always email me and let me know. We'd love to talk about this program with you. So what is the current status of screening for congenital CMV? So this map just kind of gives you an idea of where we're at in terms of CMV legislation in the United States. So currently, there's quite a few different things happening. There are some states that have targeted screening, so screening for infants who failed the newborn hearing screening. There are states that are working on universal legislation. There are states who have education requirements. So there are all sorts of different things happening right now. But currently in the United States, most infants, more than 95% of infants who are born with congenital CMV are never identified. And this is because most look typical when they're born, and because by the time symptoms show up, it can be too late to get that diagnosis. And we'll talk about that a little bit with our parent panel. But really, CMV screening is supposed to be done within the first 3 weeks of life. After that point, we can test the newborn blood spot if it's still available, but that is not always conclusive. So we have a short window to make this diagnosis usually, and a lot of times that's missed. So the National CMV Foundation plans to resubmit our nomination package for the recommended uniform screening panel. So that's a group that makes a recommendation to all the states as to what should be put on the newborn screening panel. But it is then up to each state what they decide to add. So we're working on that, and we're hoping to submit that later this summer or in the fall. But currently, congenital CMV is more common than the 29 combined metabolic and endocrine disorders that are currently on the recommended uniform screening panel. So congenital CMV is more common than what we are already screening for in the United States. What's the economic impact of congenital CMV? It's a little hard to estimate, and there's been some new papers published that indicate that we maybe don't have the best information about what the costs truly are. But I will tell you that in the 1990s, there was a paper published that talked about the economic impact and estimated the impact to be about $2 billion, and the average cost per affected child to be $300,000. So some infants and children obviously costing less and some costing more. Privately insured children with symptomatic congenital CMV had 4-year expenditures at least 20 times as great as other privately insured US children. The costs are variable from all the way from medication to hospitalization to special education services. There's a whole list of things that these children may need. Cochlear implant surgery, for example, I've read can be $60,000 to $100,000 per side. So that's obviously a huge expense to the healthcare system also. But the financial impact on families can be really hard to quantify. And sometimes people call this the disability tax. Families have a hard time maybe quantifying this number, but, just in my own family story, I mean, we built an accessible home for our daughter. We moved school districts. I work at a different job now that I did before, because before I had my daughter, I didn't even know about CMV, and now I work for the foundation full time. So, buying accessible cars, all the time spent away from work, caregiving, and then just thinking about caregiving. Some of these children will need care for the rest of their lives. So, thinking about and making plans for caring for these children, and I'm thinking about caring for my daughter for well beyond 18 years, and hopefully that happens. But just knowing that this can last quite a long time for these families. So what is the typical family experience? Well, the answer is there is no typical family experience. I think that they're all a little bit unique and all a little bit different. Just like no two kids with congenital CMV are exactly the same, no family story is exactly the same. And so some families, in terms of diagnosis, are getting a diagnosis after they have a miscarriage or stillbirth. The rate of finding that out is low, we think, but it is a significant and important cause of miscarriage and stillbirth. And so something that is worth discussing. Some families like mine, again, not the majority, are going to find out during the pregnancy. So that is certainly what happened to my family. But I think, and we'll check when we get to the parent panel, I think we're the only ones that found out during the pregnancy. I could be wrong though. But again, not nearly as common. Some people are going to find out in the neonatal period. So right after their baby is born, within the first few weeks of life, there are signs. And so so a diagnosis is made. Some children will find out after the neonatal period, in the first months or even years of life, depending upon how long that newborn blood spot card is kept. Some people can find out later. Depends on how long they have that blood sample. But the vast majority, like I said, 95%, never get this diagnosis. So there are so many, thousands of children who have disabilities and health conditions due to congenital CMV that it's never tied back. And so they'll never have that diagnosis. What's the typical family experience just kind of living with this diagnosis? There was a great paper that came out last fall out of the UK, and it kind of tried to quantify this, which I guess is kind of a difficult thing to do because these are people's experiences and everything is different. But there were some common things, and there are common things that I hear from families when they reach out to me at the foundation. So this is a diagnostic odyssey for a lot of people. Something's going on with their child, they don't know what it is, they go through genetic testing, they go through all these other things that it could be, and then maybe finally someone says, well, we should check for CMV, and then they're finally given that diagnosis. A lot of parents talk about dismissal of their concerns by the medical community, either during the pregnancy or afterwards when the baby's born. I had a mom say that her baby had petechiae, had little spots all over when they were born, and they asked, and the doctors and nurses said, oh, that's nothing, it's no big deal, it's just from the birth. So I've heard that more than once. So people's concerns are dismissed. Even if people kind of go back and not confront, but want to discuss this diagnosis with their OB doctor or their family practice doctor who is seeing them during the pregnancy, again, a lot of times their concerns are dismissed. That's not very common. That doesn't happen very often. I'm sorry that happened to you, but I've never seen it before, and I probably will never see it again. Families feel really let down by this. They are frustrated by the lack of awareness and knowledge in the medical community. And so a lot of these families feel a lot of anger and hurt that they're dealing with something that no one told them about. They're angry or resentful about the missed opportunities. I know that I've dealt with that myself. So I really feel like there was a major missed opportunity, for someone to tell me about this before I got pregnant, or, right when I got pregnant. Families are really dealing with an uncertain future. Nobody can tell us what our kids are going to be like exactly, or what's going to happen, how long they're going to live, what their needs are going to be if they get to adulthood. And so I think dealing with that uncertain future, it's very difficult for families. And the thing I hear the most, and the thing I remember saying the second the doctor gave me a handout about CMV when I was still pregnant, is, why didn't anyone tell me about this? Why does no one talk about this? Why am I hearing about this for the first time when we're seeing abnormalities on an ultrasound, or when my baby was born really sick? Why am I just hearing about this now? And so I think that that's the most common thing that I hear. And it just is exactly what I said when we got our diagnosis. And actually, that's it for my presentation. And so thank you for listening. And I'm always happy to answer questions. And the people running this presentation have my contact information. So please reach out, or you can always email info@nationalcmv.org. And we are happy to answer questions or make connections for families. So thank you so much. Hi, everyone, and thank you for joining us for the Bellisville Parent Panel. And we have several wonderful CMV parents here to talk to you about their experiences today. So I think we'll get started just by everybody introducing themselves, maybe telling us a little bit about your family's journey with CMV and a little bit about your child with CMV.
I'm Sarah Strevel, and we are from Columbia, Kentucky. That's in the south central portion of the state. Our daughter Bella was born in 2017. That was our first introduction to congenital CMV, cyclomegalovirus. Bella come along as the little sister to 5 brothers and a sister. So she was beloved greatly before she even came along. She was the last of our family, of a blended family, large blended family. So everyone was looking forward to her arrival. Pregnancy went great. Everyone was in the waiting room. But unbeknownst to us, Bella was born with a virus known as cyclomegalovirus. She had symptoms at birth. She was sent to the NICU, where we stayed for the next 2 weeks. She was diagnosed only 3 days after birth. So we did get a diagnosis fairly quickly due to her symptoms. She had petechiae all over her body. She had an enlarged liver, an enlarged spleen. She also had very, very low blood platelets. She had to have blood platelet transfusions for the 2 weeks that we were in the NICU. She was started on an antiviral, and we eventually got to go home on the antiviral with lots and lots of doctor's appointments. So by the time Bella was 3 months old, we found out that she was completely deaf in both ears. We began a journey to receive cochlear implants at that point, which she received just before she was a year old. At 6 months old, we got diagnosed of seizure disorder. They couldn't actually tell us exactly what type of seizures she was having at that point, but she was put on medication. And by the time she was a year old, we had a diagnosis of cerebral palsy and several seizure disorders by that point. And then by the time she was 2, we received Lennox-Gastaut syndrome diagnosis, which is a very rare and also very severe seizure disorder. So at this point, her seizures were out of control. We spent 6 months in the hospital at Norton Children's Hospital in Louisville, trying to get the seizures under control. We were able to control them for a couple of months, and then they started back with aggression. And so we actually lost her last year, just after her 3rd birthday, due to seizures and just complications coming from CMV, such as respiratory failure, autonomic dysfunctioning. Everything just kind of went together and created a perfect storm. And so we lost her in April of last year.
I'm Katie Wallace, and I am living in Lexington, Kentucky, and have been here for 5, almost 6 years now. And a little bit about our journey with congenital CMV. Our journey is very new in the last 4 months. So we have, my husband and I were lucky enough to have a 2.5-year-old named Emerson. And when she was about 1.5, we found out that we were pregnant with, we thought, just one other child. And it turned out I was actually pregnant with twins. We found out we were having a boy and a girl. And I'm not going to lie, it was not an easy pregnancy journey. Just a lot of ups and downs, and kind of worried just about, twin pregnancies in general and the complications associated with them. Read all the books, followed all the rules, etc., and was lucky enough to kind of during my 3rd trimester be in the clear of some previous issues I had had. And we made it to our 38-week induction date, the longest 38 weeks I think I've experienced, and had a very uncomplicated delivery. And we're just relieved to hold our twins, Ellie and Rowan, in our arms and just be happy that everyone was safe and sound. And honestly, when he was born, he didn't have any notable issues right away. He did have a rash on his face that was thought to be just birth trauma related. But pretty quickly, my husband and I noticed that he was just very tremulous, very shaky. The The rash was unusual because his sister didn't have it. And we had lots of people tell us that everything looked normal. It was within the spectrum of normal. Ellie was perfectly fine. And then right before we left the hospital, we found out that he failed the newborn hearing screen, which we were also told was very normal. And he would have follow-up in a month to get additional hearing screens. But we were fortunate enough that our hospital did targeted screening. And because of him failing the newborn hearing test, the CMV was sent. And my background is I am an infectious diseases pharmacist. And so I had heard about congenital CMV, but wasn't really educated about prevention of CMV. And so we got a call a week later from my colleague. And so as soon as I saw her name, we knew that he had congenital CMV. He was also symptomatic, we found out that week that he had brain calcifications, was pretty much had profound hearing loss on both sides, and did have somewhat low platelets. And so it was a very difficult week when we found all of that out. And since that time, we did find out, we actually went in because we thought he might be having seizures. Looking back now, he was likely having a growth spurt and just has some unusual motor movements. And so I think we got lucky in the sense that they did happen to catch that he was having seizures, but they were subclinical, so you couldn't really tell when he was having them. So he's been on medication for that and is diagnosed with focal epilepsy. And now he's 4 months old. We do have one neurologist out of 3 already willing to give him a cerebral palsy diagnosis. But otherwise, I mean, he's doing as the best that he can right now. But it's been a short journey and a long journey, kind of all at the same time so far.
My name is Megan Bowden. Myself and my family are from Louisville, Kentucky, where my daughter June was born. June was born January of 2016. We actually our story sounds really similar to Katie's, where it was not an easy pregnancy. I was very sick in the first trimester of my pregnancy. I actually have very vivid memories of talking to my OB about it and asking questions and being nervous about how sick I was. I mean, it was at certain points just not possible for me to get out of bed. I had my husband bringing me soup. I'd wake up, I'd eat the soup, I'd fall back asleep. That happened actually in the first trimester of my pregnancy, and then again in the right before I gave birth, the 3 weeks before I gave birth to June. But when June was born, I was very lucky. The birthing process was wonderful and easy. The labor maybe was 2 hours long, and she was born naturally. When she was born, it was, again, she was born with a rash on her face. We were told that it was birth trauma because she had come out so fast. But again, on her second day of life, she had failed a hearing test. We were told again that was normal, that we should follow up with an audiologist within a month or so. But then June had been seen in the hospital by a pediatrician, as all babies are before they leave. And the pediatrician was really concerned about the size of June's cranium. And so they did some measurements. They thought that maybe she could have a syndrome called craniostenosis. They took her down for some just x-rays, no CT scans or anything else, but x-rays, and found that her suture lines were normal. And as far as everything else, her APGAR scores were at a 9. And so they said, even though she has a smaller than normal cranium, she has this facial rash and a failed hearing screen. They said, it's fine, just go home and keep checking in with your pediatrician. We did that for 3 months, but things continued to decline for June in those first 3 months of her life. She kept having like illness after illness. She wouldn't sleep. There were days when there was just an entire 24-hour period where she would just scream and not sleep. And so we kept seeking out new pediatricians. We had a lot of trouble with the one that we were dealing with. And so finally we ended up, and we went to Norton Children's. We tried all sorts of different things, and we kept seeing pediatricians who were like, her head is small, and she seems really aggravated and upset. But really, all they diagnosed June with her first 3 months of life was acid reflux. After a lot of different doctors, we finally were put into Norton Children's one afternoon with June having a diagnosis of failure to thrive. And she had lost several pounds in a week. And this was, again, only at her 3-month period. And at that point, we were able to see a neurologist, a virologist, and it was at that weekend that she was diagnosed with cerebral palsy at 3 months of age. He also gave us a pretty scary diagnosis of letting us know that Junie could maybe only live to be a year, and that maybe maximum 20, but they prepared us at that point for June to maybe not live through the first year of her life, which was all very shocking. They gave us the diagnosis of congenital CMV, and we'd never heard of that before. And we did some genetic testing, but all the markers were there for CMV: calcifications on her brain, the craniostenosis, the microcephaly. She then aggressively lost her hearing and became completely deaf by the time she was a year old. And then now at 4 years of age, has focal epilepsy. The epilepsy held off for a little while, but June now has uncontrollable nocturnal seizures about every 4 to 5 months. And that's where we are. But she's also, brilliant and healthy as of right now.
Hello. My daughter is Natalie Stewart. She was born in February 2016. We just moved out to Bardstown, Kentucky. And for us, kind of got started before she was born. Me and my wife, Laura, went to the OB to get a checkup. And in that time, they noticed some enlarged ventricles. And so we're like, oh, what is that? What does that mean? And they just told us, oh, it could be nothing. Don't worry about it now. And you can't tell that to a parent right then. We went home and we Googled what that is. And, we, found CMV and started reading about that a little bit. And I'm trying to be on the bright side and maybe it's not that, because it's right on the borderline what it could be. So fast forward, the due date, Natalie comes out, all gray, flash on her face, very small for her age, but she was the biggest one of our other 2 kids. So we was oh, we got a big baby, 6 pounds 3 ounces. That's a big baby. But we have an awesome pediatrician that when we went, she caught it. But before we went to see her, she failed the hearing test. At first, did it again, pass, go check, follow up. And then she failed the car seat test. It was oh, ready to get home, but she failed that 2 times before we can actually go home. She, go to the, doctor, and head is small, rash on her face. So she, I guess, kind of knew, because our pediatrician is good, but she doesn't like giving out bad news. So she referred us to an infectious disease doctor, where they confirmed that she had congenital CMV and gave her some medicine for it, some antivirals for that. And so, we was at shock, disbelief. Then I say between 4 and 5 months, she had a seizure at night. So she got diagnosed with a seizure disorder. Then on 7 months, on Halloween, she was pronounced deaf in her right ear. And over the time, the seizures kind of got worse, but they was like really small at times, but very frequent. They would never like diagnose her with cerebral palsy at all. Nobody wanted to label her that. And honestly, I didn't want her to be labeled that because it's just, one thing you cannot overcome. That really got to me. But she's 5 years old. She's very outgoing, spunky, doing the best she can right now with everything she's gone through.
Thanks to all of you for sharing those stories. They're very different. Everybody has their own journey, but I will say I see common themes in all of them and in all of the stories that I hear working at the National CMV Foundation. So thank you for sharing. And my next question for you all is, what was the first thing that you thought or said when you were given the congenital CMV diagnosis?
The first thing was, how can there be a virus that's this deadly and this horrible, and I don't know anything about it? This wasn't our first kid. I had lots of friends with kids, and no one had ever heard about this. This was completely unknown. I'm like, how in the world can there be something so awful that we know nothing about?
Yeah, it was, yes, I think I'm just going to second Sarah. It was just so shocking that there's no information whatsoever. Yep.
I was more like, okay, what we need to do to overcome this?
I think my first thought, because I had at least heard of it, was kind of, I can't believe my worst fears in life are about to come true, which is fear of, having a child that has any struggles in life. And so sitting there, honestly, getting the phone call, looking at my husband, knowing I was going to have to explain it, was very, very traumatic.
So I'm curious, after you guys got your diagnoses and then it kind of settled in and you learned more about CMV, then where did your thoughts go? And what did you think about it after you learned a little bit more?
I'd have to say it was guilt. Everything, of course, we immediately went to Google. We immediately, you have to try to look it up and figure out what's going on. I think from the hospital, we had a 1-page handout from the CDC, and that was all the information that we had, which was very, very limited. And so we did research ourselves, but everything that I was finding was calling it preventable. So this is absolutely preventable. This is preventable. And like, if this is preventable, then that means I did something wrong. That means I didn't prevent it. That means I've caused this in some way. So, that initial shock and that disbelief, and then immediately after that was just guilt.
Yes, I agree. The guilt settled in hard. I will say that I was very lucky to come across, when we had June's genetic testing, the person who called us with June's official diagnosis and the fact that it wasn't anything else as far as her genetics. When this woman called me on the phone to tell me all of this, I was actually, it was Thunder over Louisville here in Kentucky, which is the start of the Derby Festival. It's a giant, chunk of celebration in Louisville. And I was stuck in traffic trying to get home. I worked downtown, and so I wasn't around anyone else. I was all by myself in my car. And the woman on the phone from the geneticist's office just said, "This is not your fault." And she was like, I don't know you, but I just want you to know that this is not your fault. And it was this beautiful moment that she gave me that I could just sort of tuck, in the back of my mind and keep with me all the time, because I don't feel like the messaging that is given by other organizations lets mothers know that it's not their fault, and that, there aren't very many support systems for mothers in this country. There's a lot of messaging that everyone needs to work, be a working mom, but be a good mom and do all of the things at the same time. And, but then when something goes sideways, there's not a lot of support systems that sort of churn into gear. I mean, there are first steps in Kentucky, and that was a giant saving grace for us. But otherwise, it was, you were left very alone, and very alone with your thoughts and Google. And you have to build, just like Sarah has built in Kentucky, you have to build your own network from the ground up. I felt like when you got the diagnosis.
What a gift that woman gave you, telling you that right away. That's so wonderful. I wish that all people would get that message when they get their diagnosis, because you're right. It is, and it is not your fault or anyone's fault when they get this diagnosis. So that's so great to hear that you got that from her. Katie, how did you feel after? Well, and you're still settling in, but how did you feel? As this news kind of settled in a little bit.
I think it was all the emotions that everybody else mentioned. Guilt was really bad. I felt like I had heard about this. How did I not know to prevent it? This is going to sound weird, but I also bite my nails. And so I was like, man, that might have been I just thought about everything. And so guilt was a big one. But then I also think just fear. I mean, you start Googling, it's basically a whole unknown. And so I think just complete fear, and then exhaustion, because we had a toddler and twins, and we kind of felt like, was a toddler and twins not enough? Now we have this chronic medical condition that we're going to have to deal with. And then I was obviously still very hormonal. So it was all just a very dark kind of swirl. And how do we get help, and what are the next steps? And I'm very type A, so I think it was hard trying to figure out how to do what was best for your family, but also figure out how to take care of yourself, and just make it through each day. And so though there was no emotion I wasn't experiencing, I think, in those initial few weeks to months. We probably just started accepting everything, probably honestly in the last 3 weeks.
It's definitely a journey to acceptance. And I feel like you go through acceptance, and then I feel like accepting again, and then you go through it again. It's almost like a circular thing that happens over and over. So definitely can relate to that. Jeremy, how about you? How were you guys feeling once this settled in? Or maybe you want to share your perspective on, being a dad of a child with CMV, and how that, felt as the diagnosis settled in.
Yeah, definitely. Because what I'm hearing from everybody here is definitely like what my wife went through. And I'm not going to speak on her behalf because I can't feel what she felt. But with me, after knowing about it and Google, becoming a best friend, it's like, I think Sarah mentioned this, like her first thought with this. And I guess from a dad's standpoint, it's like, a little bit slower. It's like, how in the world can this virus be like well known and everything, and there's not that much information about it? And that's one thing that really stuck out after doing all this research and looking this up. It's like, wow, it's affected this many people, and not many people know about it. Like, it's not out there, and it should be.
Yeah, absolutely. I think everybody has kind of these similar feelings, but in the same vein, everybody handles this a little bit differently. And I know one of the things I struggled with the first couple years was other people saying things to me like, telling stories of someone that they knew who was born with a disability but ended up graduating from Harvard, you know, these inspirational stories. And that was hard for me to deal with, because I thought, well, are you saying that if that doesn't happen, that Pippa isn't wonderful and great and isn't a success? Because, you know, she might not be the 1 in a million person who can overcome these odds. And it's difficult, because no matter how hard she works or how hard we work or anything like that, there are some things that you really can't change. And I know that that's been hard for us. Does anybody else have any thoughts on like things that people have said to you, maybe well-intentioned things that people have said that are difficult? I'd love to hear that too, because I think people don't always know what to say when something like this happens. And so sometimes people can learn a little bit from us as to what is helpful and maybe what is not.
I kind of have one example just over the last few months. Fortunately, we've been surrounded by, I think, similar to what like Megan's experience, people who've said a lot of the right things in the right moment and have been like, honestly, such a godsend to us. But I think one of the biggest things is the success stories related to children with hearing loss, like specifically. And I think it's because many people don't understand that congenital CMV has more that comes with it than hearing loss, which in and of itself is extremely difficult. But it's kind of hard explaining, like, well, my fears are, of course, confirmed that he has hearing loss and he's going to need cochlear implants. But there's also the seizures and the possible cerebral palsy and the possible this. And so it's just, I never thought in a million years I would ever think, man, if hearing loss ends up being our biggest battle, or if he doesn't have seizures, we're really lucky. Like, it just feels wrong to think that. And that's where we are. Yeah.
What do you think, what do you want doctors to know about CMV? Maybe a doctor has said something to you that wasn't true, or has given you false information about CMV, or maybe you just feel like in general, there's a lack of awareness among doctors. What do you want doctors to know?
You know, I don't think I ever expected to have to educate professionals. You know, I don't think anyone prepares for that. You know, I am from a small rural community in Kentucky. So, you know, we are limited on doctors and hospitals, but I just never expected to have to educate so many professionals. You know, it was really helpful if they just knew what CMV was. So when we found 1 or 2 people and they actually knew what cyclomegalovirus was, that was such a comfort. So, you know, this is not that rare. You know, people need to know about this. Our doctors need to know about this. You know, our family and friends, they need to know about this. You know, just to know about it, the education part, it's, yeah, and the awareness.
The thing I found in talking to doctors is all of them have definitely said, oh yeah, I absolutely know what CMV is. I think one of my more frustrating moments throughout this journey was after we learned June's diagnosis. I called the OB's office and said, hey, I wanted to know if you guys ever give CMV tests to pregnant women. And the woman who I spoke to said, yes, we do. And I said, okay, well, I would definitely asked about being sick during my pregnancy and wasn't offered one. When do you offer a CMV test? Because I'm confused if it's an upper respiratory, but an upper respiratory that can then cause severe damage to a fetus. I know that's on my file that I had that. And she said, well, we just don't often offer them because they're really expensive. And that was wildly frustrating and sad, because I have an entire table full of medical bills down in my basement that has taken me years to sort out for June. And I still, every year, I always fall behind with all of her medical bills and all of the different things that I have to keep track of. And man, it would have been really not that expensive to have a CMV test when I was in the beginning of my pregnancy. So I think just not being afraid to, do the early testing, to make that leap, to offer it to women and say, hey, you can, pay this out of pocket if you want, but then you have all this extra information if you know that you come up positive.
I think mine's more specifically for OBs, because all of my other doctors have been very aware of it. I just think about the number of appointments I had and the number of opportunities to say, like, you have a toddler in daycare, don't worry, too much about it, but just be sure you're not eating after her, which I do all the time. And, and it's not that I would have freaked out if I shared a spoon, but maybe I just would have done it less. Or reduced my exposure somewhat. And it goes kind of, I think, back to that whole guilt issue. And for some of us, there was nothing to prevent. We still don't know how we got it, but there are modifiable risk factors that I think are important to be aware of. And the last thing is, I went back to my twin book that I read front to back, over 300 pages. And it was the one book I read, and they have an infection section. And there is nothing about cytomegalovirus, not a thing. And it just blew my mind that here they talk about all these other infections that are way less common, like don't clean your cat's litter box because you might get toxo. And yet we don't talk about, CMV. So
through this whole journey, the one doctor I talked to and Laura talks to is that, they may say they know it, tell you a little bit what they know. I just wish they was more conscious and aware of like the signs and like act upon it for the testing, and not just wait until a definitive answer, and actually listen to moms. Like, I know as a dad is like, we kind of go like, oh yeah, you just, think, no, listen to the moms, and they know. Just check and make sure she's not around. Yeah, they listen, because they know what's going on. And another thing is like, I wrestled with this one because we was told that Natalie would never walk or talk at all. I think she was 3 months old, and like coming from a dad standpoint, it's like, no, we kind of want to fix it, or like, oh no, there's a way. There could definitely gotta be a way, but definitely like be more conscious and act upon the stuff and listen to moms, and don't just go ahead and say what the child can and cannot do. All right, keep that stuff to yourself because you don't know. You don't want to give them false hope. Okay, you don't want to give them anything negative. You just tell them like, this could happen, not like, oh yeah, definitely it's not going to. Right.
Even if they've heard of it, I think sometimes the knowledge of how common it is just not really there. So thank you all for sharing that. I don't always love focusing on the financial aspect of having a child with a disability or with special needs, but I think it's important because people respond to it. And so I'm wondering if people can talk a little bit about the financial impact that this has maybe had on your family, and maybe talk about some of the costs that people don't think about, or costs that are hard to quantify, but that are really important for people to know, because this is not something that is cost neutral, right? This is something that costs a lot for the healthcare system, for families, for parents, and it's not just dollars. It's also things that can't be quantified. So, Megan, do you have any thoughts on that?
Yeah, I mean, from the beginning of all of this, I actually was the breadwinner in our family before June was born. My husband had a small business that he was starting up, so I was the one that went out of the house, like made sure we had health insurance, got the sort of typical job. But when we got June's diagnosis, I didn't see a way around. The daycare that she was in said that she couldn't be there anymore, and I didn't see a way forward. I already had taken so many days off after coming back from a maternity leave that was only 6 weeks long. And so after coming back from that short maternity leave and then having so many sick days because June was so sick and we didn't know what was happening, once we got the official diagnosis that she had quadriplegic cerebral palsy and all the other things, I quit my job because I didn't know, I couldn't see a way forward with being able to be at my job and also understanding this virus and understanding its effects on her. I knew that if she couldn't be in a daycare, then, we had to basically realign everything in our whole family. But for the first time in not being a breadwinner, I had to then, start navigating the Medicaid system in Kentucky. And that became a full-time job in itself. I'd sat for hours in what's called the L&N building in Louisville, Kentucky, I've sat there before with stacks of paper only to be told that I was missing one and needed to go home and come back. I've even had social workers come to our house to try to make the process easier. June has been on the waiting list for the Michelle P. waiver since she was 6 months old, and she's still 1,164 down from ever seeing it. I don't know if in June's lifetime she will ever be on the Michelle P. waiver at this rate. We've tried to get on the home and community waiver, but I think what I've been struck by as a college educated woman and a woman that was very much proud to be in charge of my future and my family, I have been really struck by how difficult it's been to navigate the Medicaid system in our state and how hard it's been to get the things that we need for June to have the treatment that she needs, whether it's just an hour's worth of therapy 1 day a week, or if, we've been through times where I had to reach out to my congressman, which is Congressman John Yarmouth, where June had lost her Medicaid, but I could not get anyone in the Medicaid services department to even advocate for June to get it back. And I remember talking to a woman who said that, she could see the problem, but she didn't want to fix it because she could lose her job. And so that was right before June's cochlear surgery. And that surgery would have amounted to close to $200,000. And we would have had to sell our home. I don't know what. That's been my biggest struggle with this, is that I still am not back in the workforce because I've tried to rejoin and I've had part-time jobs, but at this point, I'm not sure how. I don't see a way forward for me to have a full-time job, but then still be a proper advocate for June and for her to make it to all of her medical appointments while someone employs me full-time.
The cost, I was never able to work full-time. I've barely been able to work part-time. And then in the end, she actually, for the last year, she required nursing care just about around the clock. She was a 2-person job. I had to be here along with the nurse. It wasn't something where you can have a nurse and then you can go off to work. No, it was around the clock. The travel, we stayed for 6 months of her life in the hospital, bedside. That was between the ages of 2 and 3. You have meals, you have gas, you have, all the bills at home piling up. Purchase of a handicap van. Nobody pays for that. We didn't have anywhere to take her anywhere. I mean, we couldn't have even took her to the hospital without a handicap van. That we had no way to get her in and out of the chairs, not safely. It's just been a fight. The cost of fighting for it all, I think, has been more than the financials, even though the financials have been great.
Yeah, I hear that so many times, that this fight is just so exhausting and it just never ends. There's always something you're fighting for or advocating for, or something that insurance isn't paying for, and they're hoping that you give up and just stop pushing for it. And so it's so hard to just keep that that fight up, and it's exhausting emotionally and physically and in every way. Jeremy, how about you guys? How has this impacted your family?
Laura does all that, like Megan and Sarah does. She fights for it and on the phone calls, and it's exhausting. Like everyone said, it is, and I can see it firsthand. And she's always on like, why am I so tired after this? And like and all that. It's like phone calls and make sure they do, make sure they the medicine goes through, or the therapy, or this piece of equipment. And you constantly have to get on them, and they always give you the runaround, like, oh no, it's not us, you need to call this person, and then go back to this one. It's back and forth. Dang, like you're in a tennis match, and very frustrating. And I sit down, I'm watching Natalie and just hearing Laura on the phone. It's like, I don't know how you do it. I don't know how you have the patience to do it. Like, I would already lost my mind over it. And we probably wouldn't have probably most of the stuff that we have now if it wasn't for Laura, for being so patient and doing that. And we all know medical equipment, supplies, hospital stays, medicine, therapy, the cost is a lot. Even, vehicles, it's a lot. And one thing people don't understand is like the time away from your family. If you have to go to a hospital, like I mentioned earlier that we had a hospital stay, and it was just supposed to be for 2 weeks, and it ended up being a month. And having 2 other kids, and it's like, it's not a toll just on Natalie, and not just on me and Laura, but also on our other 2 kids. And like that, that month is like, we missed. And like, yeah, the hospital stays can be almost $500,000 or more. But that's nothing compared to like stuff that you miss with your family. I don't know if you can put a number on it. That's just one side that, nobody tends to think about. And the time to spend like calling about this and sitting in lines and make sure you have every form, okay, dotted and crossed and filled out. Like that's time away from your kids, from your family, to taking care of your own child. And there's like, oh no, you're getting this, but like, I used to be a full-time employee. I used to help my family out, and yeah, this stuff is great. Like, what about this other stuff too? Like, they forget about that stuff. It's like the mental strain on it is a lot. And we see ads, and it talked about like it's Mental Health Awareness Month. It's like, where's that help at? Like, really? Like, I mean, I can support my wife so far and help her out so much, but then it's there has to be other things too to make the system a little bit easier for the moms or dads that have to go through this. And they're like, oh yeah, it's easy, just fill this out, and oh, don't forget the fine print now, and make sure you have this done. And like, it's very frustrating, to say the least.
Thank you, Jeremy. I appreciate that perspective, and you are so right. And I'm so glad that you brought that back to the mental health side of things. And it's so true. We're not just these kids' parents, we're their nurses and their teachers and their care coordinators and their social workers and all these other things. And the emotional, physical strain and impact you cannot measure it. It is immeasurable. And there is no way to put a price tag on that. And you guys are all right. You're all correct. And thank you so much for sharing that piece of it, because it's really important for people to understand that this doesn't just impact the child, this impacts the whole family, and it ripples out and affects the whole healthcare system. And this is a whole, congenital CMV is a huge issue. So thank you for sharing those perspectives.
You mamas out there, dealing with all this, I envy you. You are like superheroes, because I can tell you, like, firsthand, I couldn't do this. I mean, I probably could if I didn't have Laura, but like, you guys are amazing. I just want to let y'all know that, like, truly.
I also want to commend Jeremy for being on with us, as a father and, not maybe the primary caregiver. I also have a partner who has been right there next to me this entire time, but it's been really hard. It's hard on couples, it's hard on a marriage, it's hard on families. Because we kind of become this do it all superwoman. And you guys have to support us and still being able to try to understand, even though you're not there for the significant part of the day, being able to come back in and give us a break and still be strong for us. It's truly is a whole family dynamic. And one of the questions that you were going to ask was the impact on the family. And this has impacted my family. We lost Bella, but my family will never be the same. My family, my kids will never be the same, and not just due to her loss, that has been very impactful, but it's not just due to loss, CMV and her disabilities, her uniqueness, the specialness, all of that has just changed who we are as people and who we are as a family. We do everything. I don't know that we do anything the same. It feels like we do everything different.
Yes, there is no aspect of our lives that are the same. It's like pre-diagnosis, post-diagnosis, and things will never be the same. So I totally agree.
As far as family impact and the financial impact, speaking of it, like trying to concise all of that down together. I mean, not only are we a different family before and after the diagnosis, but like prior to June's diagnosis, we had, for example, a rental property, and my husband had his own business, and I was the breadwinner. Like we had 401ks, and we had a savings account and all of these things. And another thing that's really struck me about being in this position now with June is that in order for June to get all of the services that she absolutely needs, being a child with multiple disabilities and needing to be on a waiver, we've had to give up everything. Like, we can't have multiple vehicles. My husband couldn't have his own business with multiple vehicles. He had a roofing business that was really like going exceptionally strong. He had to liquidate that. We had to get rid of our rental property. I mean, this is in revenue also that, like, I realize that someone else in the state might pick up, but that's revenue that the state has lost from us working and having these businesses. And now it's done. I mean, in order for June to get on the home and community waiver recently, I had to have a letter stating that none of my children have a savings account. And I had to call our bank and say, can you please give me a letter saying that none of my children have savings account, and so that I can put my daughter. And the person at the bank was so confused. And they're like, what you want a letter saying you don't have a savings account? And I was like, yes, I need a letter saying that no children in my family have a savings account, because if they do, then my child might lose services. And that is something that I'm very baffled by with the financial impact to our family. I mean, we were on a completely different trajectory as a family. We had safety nets and careers, and now we mainly are working to be advocates for this one person in our family and make sure that she has the things that she needs.
Absolutely. The whole life is just taken on a completely different path. Absolutely. And you're right. You cannot underestimate the financial impact of that. So our last question is really, I'd love it if you would share what your favorite thing about your child with CMV is or was, and kind of if you have a closing remark or just something that you want to leave the audience with. Katie, why don't you go first?
So this was definitely, I think, one of my favorite questions. But my husband and I actually kind of were talking about this, and I think our favorite thing is when he was born, we would joke that he has an old man face, like a grumpy old man face, because he just always looks so serious. And but the reality is he's like such a happy baby. And when you tickle him, he just laughs and gives you this big smile. And so you have to work for it. And I love that about him. Like you have to work for the smiles and the giggles, but they're just so fulfilling. And he also has this like really fuzzy head that I also love. Since he's so little, the things, of course, are slowly becoming personality things, but it's also physical traits. And I think just, I guess, kind of a last remaining remark is I think what's been hard is, and that I kind of hate about all of this, is I would take away CMV from Rowan in a second. But it bothers me that it's kind of taken something like this for my husband and I to really stop and like reassess our lives and focus on what's important. And I think about how much time we've wasted. Like I said in my thing, we've literally lived more life in 4 months than in my 32 years. And it's really just made us think about like what's important and what to focus on. And it bothers me that it takes something as terrible as this for that to be the case. But I just hope that, other families don't have to go through something like this because of families like ours being able to raise awareness and education.
Thank you, Katie. I love that. That's the perfect answer. Sarah, what do you want to tell us your favorite thing about Bella? And if you have a closing remark.
So I'd have to say the favorite thing would be her laugh. She had the most infectious laugh. The doctors would come and stop by the room just to hear her laugh. We would put her on she had a respiratory vest that she wore and she loved it. And so she would sing and laugh while she had it on. And it was it was a sight to behold. So her laugh and her personality, she has such a strong personality. Everything had to be Bella's way, and I think that's part of what she's taught us too was, not be afraid to take what you want, or to fight for what you want, and we continue to fight for her, and she taught us how to do that. She taught us how to live every day and not take it for granted.
Thank you, Sarah. And Megan, tell us your favorite thing about June, and if you have a closing remark.
I'll just tell you my favorite thing about June. I think between Katie and Sarah, I don't know if I'm going to be able to keep talking without crying. So, but my favorite thing about June is, getting the diagnosis that she could only maybe live a year. Again, we were so scared and we didn't know what her future was going to look like and how much medical intervention and all of those things. So I just remember thinking to myself, like, wherever you go, I'll follow. And there was like one really scary moment where early on she was arching a bunch and was kind of in a bad place, and she was sick and screaming. And I found her in her bassinet with her head sort of lodged in a place where she couldn't breathe. And it was so terrifying. And I was like, oh my God, if I'm even a few steps away from her, I'm going to lose her. But I picked her up and she just gave me like a giant smile. And I was like, okay, well, if this is the fight in you, like wherever you go, I'll follow. Like, if this is how we're going to fight and you're never going to back down, then I'm not going to back down either. We're going to do this. So it's, yeah, I think that's about it. But yeah.
Good job, girl.
That's perfect. I love that. Wherever you go, I'll go. That is so true. That is so true. Jeremy, what do you want to share about Natalie, and do you have any closing remarks?
I don't think I just have one thing with Natalie. It's, her laugh, her smile, her persistence, her patience, her joy. It's one thing with her is like that has taught me definitely is like the joy and everything. When she had a procedure done and she had to get all her hair cut off, and it's hair, it grows back, but it got to me, got to her mom, and like she took it like in stride and was like just rubbing her head. I was like, oh, okay, I'm like daddy now. That was no big deal, and she just like moved on.
You're gonna teach her that. Remember, you was teaching her ways. Now you're gonna teach her to blow kisses.
Like I said, it's just like wherever you go, I'm going. It's like that's awesome. It's like, and it's so awesome that they're like that. These kids are so resilient and joyful. Like it's, and I close with most people like roller coasters, and as a parent, it's an emotional roller coaster. It has its highs, it has its lows, but the thrill of getting on a roller coaster and enjoying it will beat out probably any fear that we have if we have that mentality.
Thank you so much for sharing, you guys. Those were all wonderful. That just brought a tear to my eye and a smile to my face. So thank you for sharing about your kiddos. Well, thank you all for joining our parent panel, our Bella's Bill parent panel. And I'm so honored and privileged to get to ask you all these questions, and your responses were just wonderful and perfect and just so informational for people wanting to learn more about this. And I think that this is really going to help other families and people who are wanting to understand the impact of congenital CMV in your state, but also just across the country, because this is a problem everywhere. And so we thank you so much for your time, and thank you for joining us.